So, sir, is 3, 2, 1. So we are live to.
Good morning, everyone. So like every second Sunday of the month, so this second Sunday we have started with another ICOG academic program for the postgraduate students. So we would like to sincerely thank. I would like to sincerely thank our FOXI President, Dr. Bhaskar Pal sir, ICOG Chairperson Dr. Sheila Mane Madam, Chairperson-elect Dr. Ashok Kumar, Vice Chairperson ICOG Dr. Sadhna Gupta, then FOXI Secretary General Dr. Subarna Khadilkar, ICOG Secretary Dr. Pratik Tambe sir for continuing these academic programs. And we have been able to do this program for the last 5 years, and all the programs are in record in the ICOG website as well. So we'd like to have start this program. Ashok sir. So for the first, I would like to have request our ICOG chairperson, Dr. Sheila Mane Madam, to say a few words.
Is Dr. Ashok there?
Am I audible?
Yeah, ma'am, sir, we are searching.
Yeah, let Dr. Ashok speak and then I.
Yeah, yes, sir. Yes,
Yes.
sir. Yes, sir, yours. Yeah, I can see you now.
Okay. So, good morning. Am I audible?
Yes, sir, you are audible now. Hello.
Good morning.
Yes,
good morning. Am I audible?
Yes, sir. Yes, sir.
Sir, you are audible. Please go ahead. You are not visible though.
Yeah.
You are audible, sir.
Good morning. I am today at Lucknow for a conference of Dr. Kumar. So, welcome you from Lucknow. This is FOXI ICOG PG clinic. This is the month of second Sunday of the April month of 2000, and we are here once again for a beautiful and very program for PG students. And before I start, I would like to express my sincere thanks and gratitude to see President Dr. Bhaskar Pal, our ICOG chairperson Sheila Mane, and the whole team of ICOG for giving us this opportunity to have this program. The program is now in the 5th year, and today we have eminent faculty from different parts of the country, and I welcome you all. And I thank you also for spending your valuable time for this program. So before I proceed with the program and I introduce the faculty, let me invite our person, Dr. Sheila Mane, for her remark. Madam, please.
Yeah. Good morning and thank you, Dr. Ashok Kumar, for those kind words. And I think I really appreciate the interest and the passion of yours since you started this program, and it's on since 5 years. And it's of immense importance, as here the program is conducted keeping mainly the focus on postgraduates and their exam pattern. And I think all the senior teachers really see to it that the students are prepared. So that way it is structured. And you can see that the first part concentrates on pelvis or labor, like Dr. Chitra is going to talk about protracted labor and all those things. And then we also have the class by Dr. Anupama on specimens, as well as the case discussion. And thank you, the Silchar Medical College professors, for allowing your students to present. And I think they're going to do a good job, as well as the other eminent professors from different medical colleges like Dr. Padmaja, Dr. Upma, Dr. Roop Kala, as well as Dr. Jasmine, joining in from medical colleges from all over the country. And the students have the privilege of getting exposed to so many examiners Like you get examiners from different states, so you have the privilege of that. Those who are presenting, of course, but those who are attending also. And I know that we try to see that it reaches more and more students so that they take the benefit. As you're sitting at home or wherever you are working, also you can listen. And Dr. Ashok has really come out with this innovative idea, and which I really appreciate. And thank you, Dr. Ashok, for bringing up this, as well as Dr. Hafizur for constantly working with this session, and Dr. Ashish Mukhopadhyay, who is also constantly there with us on every second Sunday. And this year, I think this is our third program, and I can see that it's becoming more and more popular. So, and also our Dr. Archana, who is the chairperson of quiz. So we also have a quiz on the same topic, whichever is the case discussion. And I think today's topic is very important, that is FTR. So I wish all the best to the students, those who are going to present. And thank you all for joining, and thank you for accepting our invitation. All the best. Thank you.
Thank you, madam, for your kind words. Let's start the program. Before that, I would like to just inform all of you that the recording of the programs, previous one and this one also, are available on ICOG website for your review, and you can recapitulate the learning which have been there in previous sessions and previous clinics. Today, we have structured our program. We usually starts with the doll and dummy, and we try to talk about labor. And we have Dr. Chitra from Coimbatore. She will be talking about master dummy pelvis. And then we have a case discussion from Silchar Medical College. And we have students, Dr. Hiba Rizwan and Dr. Ahmed Ali. And the faculty are Dr. Parnoy Rath and Dr. Ahmed. Grateful to you for coordinating this exercise from friend. The faculty for today, we have Dr. Padmaja from Kim Hodder, Mumbai, Dr. Uma from Delhi, Dr. Jasmina William from Neshwar, and Group from Vendor. After that, we have a session where we the master technique, that is the skill where we following the NMC guideline, and we try to give about skill or something. So now we have started specimen, how to go about the specimen by the exam. So last time also it was, we found interesting. You have really appreciated the efforts made by Dr. Maji. So today Dr. Anupma Dave from Indore, she will be taking Viva Voci for a gynecological specimen. And after that, we have a quiz by Foxy, Dr. Archana on SGA. So this is the whole activity today. And we have with us our coordinators, Dr. Ashish Mukhopadhyay and Dr. Hafiz Man with me. So I invite Dr. Ashish Mukhopadhyay to say a few words. Dr. Hafiz Man will continue the program.
Ashish sir, you are there?
I think they're facing some network issues. So let me just begin by thanking our coordinators, Dr. Ashok Kumar, Dr. Ashish Mukhopadhyay, and Dr. Hafizur Rahman for taking forward this PG clinics in so many years. Despite network and traveling issues, both Dr. Ashish and Dr. Ashok have joined us. I had the good fortune to be in Silchar just last month, and I could meet in person Dr. Pranay Nath and Dr. Fuzail Ahmed. They're both very eminent and amazing teachers. I'm sure the students have been prepared well. And the other faculty who are going to be here, Dr. Padmaja is, of course, one of my own teachers since about 30, 40 years ago. Dr. Upma Saxena, I know very well. She's from Delhi. And Dr. Jasmina Begum and Dr. Uppkala also will be joining us. So Dr. Chitra is a legendary professor, as all of us know, and she's going to be taking the first talk on dummy pelvis. May I request Dr. Hafizur to formally introduce her and get the program started?
Yes, sir. Thank you so much, Sheila ma'am and Dr. Pratik Tambe sir. So without wasting any time, we would like to start our first session, and that's very an important session, which is goes with the session related with dummy and pelvis and liver. So for the first session, the topic is on prolonged labor and obstructed labor. I would like to invite Dr. T.V. Sitra Madam. Madam is professor and unit head at PhD Institute of Medical Sciences, Coimbatore, Tamil Nadu. So before we start, Dr. Ashish sir, anything you would like to say because you have got disconnected? Sitra
No,
ma'am.
nothing more. Yeah, thank
Yes,
you
sir.
very much, Hafizur.
Yeah, I know, sir.
All of us know that this is beyond 5 years of this PG clinic continuing, and new things are evolving. And every time we start with the dummy doll and the case presentation, and this time we are going to show you show the students obstructed labor. It's good to remain in touch with the obstetric things and also the gynecology. And
Yes.
I'm very pleased to see that the students are very, very enthusiastic about this program, still continuing, as the faculties are also. So I wish this program a longer success. And thank you, the Foxy President, the ICOG Chairperson, the ICOG Secretary, and all the people associated with this program, including myself, Dr. Ashok Kumar and Dr. Hafizur Rahman. Thank you very much. Let us begin the procedure now.
Thank you so much, sir. Over to you, Dr. Chitra Madam.
Can I start sharing?
Yes, please, ma'am. Please go ahead.
Okay. Is it seen?
Yes,
Yes,
ma'am.
ma'am. You are audible and visible.
Okay. Very good morning. And at the outset, let me thank the ICOG faculty for having given me this opportunity. A special thanks to Sheila Madam, Dr. Ashok, and Dr. Hafizur for having invited me for this program to talk about prolonged labor and obstructed labor. Now, so coming straight to the topic, all of us would like to have a normal delivery, but you must know what is abnormal labor. Now, abnormal labor means there could be some problems related to all the three P's. You know, it could be because of faults in the passage, it could be because of faults in the passenger, or it could be faults in the power. So today's main discussion is what exactly do you mean by prolonged labor? What are the factors which is operating in prolonged labor? When do you say labor is prolonged, and when will you come to a stop or terminate the pregnancy and take her up for a cesarean section? Because now worldwide they've seen that the cesarean rates are increasing. Because the cesarean rates are increasing tremendously, one of the most important cause for increase in cesarean labor rates is failure to progress. I'm sure as postgraduates, you would have written many times, common indication is failure to progress. So you must know what exactly you mean by failure to progress, because left alone, there are various studies, as my talk goes on, I will tell you, there are many studies which says that labor, even if you leave for some more time, they will be able to ultimately deliver vaginally. So you must know when to put an end to this prolonged labor. Okay, so coming, so it's like I said, it's one of the most common indication of intrapartum cesarean section worldwide. And one of the most important challenges is to identify what is prolonged labor and how do you manage. Now, we just looked up the dictionary. Prolonged labor, there are so many terminologies. So it's very, very different. What you think is prolonged labor might be different for another person. So the various terminologies could be failure to descend, failure to dilate, a prolonged second stage, prolonged latent phase. There are so many terminologies. So you must know exactly what terminologies you will use when. Okay. Now, I'm sure all of us know about this Friedman's curve. Now, this Friedman's curve was started in 1950, where Friedman identified 500 patients in labor, and he developed a graph known as a Friedman's curve. Now, after this graph, they've divided labor into two stages. One is the latent phase, and the second stage is known as the active phase. Now, during the latent phase, what really happens is it's mainly the cervical changes. Now, you know that labor, cervix is closed before labor, and then it's a uterus which is relaxed. But as labor progresses, effacement occurs. Effacement is nothing but taking up of the cervix into the lower uterine segment, so that you don't have two separate cavities. You don't have a cervix and you don't have a uterine cavity. It becomes continuous as one single uterine cavity. So that is what really happens in the latent phase. The effacement of the cervix is complete, and the cervix also dilates to a particular level, maybe around 3 to 4 centimeters. That is what Friedman said. So this change is happening over the latent phase. And after the latent phase, the active phase starts, which is roughly around 3 centimeters. That itself is divided into 3 phases. One, you have the phase of acceleration, then you have the phase of maximum slope, and thirdly, you have the phase of deceleration. Now, phase of acceleration from 3 centimeters, there's a rapid progress in labor, but the maximum, it's only during the maximum slope that the labor advances very tremendously. It is said that patients can even dilate at the rate of 4 or 5 centimeters in a primary and maybe around 5 centimeters in the case of multi, and subsequently have the deceleration phase. Now, the deceleration phase is nothing but the taking up of the cervix or withdrawing of the cervix as the head descends down. Now, there's a curve which all of us have been following till very recently, a few years ago. And based on this curve, the partogram started. Now, this curve was started because many people are, it's not always an institution delivery that people come to. Many deliveries are being conducted by midwives. So they should identify when a person, there is a problem in labor and when she has to be referred to a higher center. So because of this, WHO started having this partograms. The initial partogram is what you see on this side and the left side. That included the latent phase, and then you have the 2 lines. Now, these 2 lines are actually known as the alert line and the action line. For those of you who may not be using this partogram, what exactly is the alert line? Now, this alert line is started from the dilation of 4 centimeters. So at that time, WHO said 4 centimeters should be taken as the active phase. So from then on until full cervical dilatation is 10 centimeters. So 1 centimeter per hour is what is the expected rate of progression. So if you see a person at 4 centimeters at 8 o'clock, you have to have 1 centimeter per hour. So that means roughly around within 6 hours she should deliver. So that line. So you predict that she will deliver at the rate of 1 centimeter, or she will dilate at the rate of 1 centimeter per hour. And that line is known as the alert line. Now, not all patients will deliver at that time. They might take a little longer time. So you have an action line. Action line is drawn 4 centimeters lateral to this alert line. And if a person, you can see in this graph, this is a patient who's been delivering. This is a partogram. I'm sure all as postgraduates, all of you must do this partogram. This is the line which is there. So the patient has crossed labor and then she started 4 centimeters. After 4 hours, she's only reached 5 centimeters. I mean, yeah, it's around 5 centimeters. And then she's maintaining at 5 centimeters even after 4 hours. So she's crossed the alert line. So that is an indication where you can no longer continue the pregnancy. You may have to do a cesarean section, find out what is the reason and do a cesarean section. So this partogram, WHO partogram, is what all of us have been using for centuries. But now, there's another example of this same partogram. It's the same thing. Labor is crossed the action line and there is no progress. The patient has been decided for a cesarean section. Now, everything went on fine till 2010, when suddenly Zhang identified that this is not the pattern that people, in laboring people in these days. There are lots of changes in the type of patients we have. Most of them are elderly. Most of them are obese. So the same pattern what we were following, what treatment set was different, and you have a lot of changes. So he studied he recruited more than 2 lakh women all over 19 hospitals in US. And finally, he after exclusion criteria, he studied around 62,000 women, and he came out with a different pattern. So that's what is known as the safe consortium of labor, that's the latest which all of us are supposed to know, because all your recent guidelines are based upon this safe consortium of labor. So he decided that you don't have a latent phase and an active phase. In fact, the active phase, it's a smooth curve. It is not like what you saw in the Friedman's curve. And he says that active phase only begins at roughly 6 centimeters. It is not 4 centimeters like what we thought earlier. So that's an important point that is speeches all felt must know. Labor, the active phase starts at 6 centimeters of dilatation. And this is a graph showing what happens between primary paras and what happens between multiparas. You see here, the active, it's definitely a sharp demarcation happening. And multiparas individuals, the time taken to labor is much faster than in a nulliparous individual. And here we can see the point of inflection. There's a sharp turn. It's not like how you see in primary gravities, where the curve is a little more smooth. Whereas here, the inflection is around 6 centimeters. You say there's a sharp rise. So that is what he said. So this again by dilatation, what is the time taken for different individuals. So this is comparing your Friedman's curve and your Zank curve. This is your Friedman's curve. So you have the lactant phase and then you have the active phase. But here, this is your the curve is much more smoother and it takes a longer time. Okay, and your active phase only starts at 6 centimeters of dilatation. Now, so Zank, he said, now basically all the things that Zank said was your labor starts at 6 centimeters, active phase starts at 6 centimeters, and the time taken to reach 6 centimeters itself might be long. Earlier on, Friedman said roughly latent phase will be around 20 hours in a primary gravida and 14 hours in a multigravida. Now, he said it might take a longer time, but once she reaches the active phase, you just look at this graph. From he's roughly taken at 2 centimeters. To reach, let's imagine 4 centimeters, because all of us are familiar with the Friedman's curve. From 4 centimeters to reach, you just see from 2.5 to 3, it might take 1 hour or even 7 hours. So when they're admitted at 5 centimeters, the amount of time taken varies. It's not 1 hour per hour, it takes a longer time. What he said was from 4 to 5 centimeters, persons can take even up to 5 to 6 hours. And from 5 to 6, it can take at least around 3 hours. So labor itself, even if they reach 4 centimeters, it may take a long time. After 6 centimeters, it may take up to around 8 centimeters for a person to, 8 hours for a person to reach 10 centimeters. So basically, what you have to understand is labor is not 1 centimeter per hour dilatation. You have to give a longer time. So based on all these things, ICOG in 2024 came with certain guidelines. You have 2 types of disorders. You have a protraction disorder and you have another arrest disorder. Protraction disorder means labor is progressing, but labor is progressing in a much slower rate than what you anticipate. When you say arrest disorders, that means there is no progress at all. Patient either where you assess labor progression by 2 things. One is a cervical dilatation and the other one is a descent of the fetal head. So you will say there is no, there is an arrest disorder if the cervix does not dilate any further or the head does not descend any further. Then you say, I will tell you the timings in this talk, I will tell you the timings. What is the timing to say it's an arrest disorder? So protraction means labor is progressing, but it is a much lower rate than what you anticipate. And arrest disorder means there is no, neither a descent of the cervix nor a dilatation of the cervix. So, like I said, when the labor is less than, in 2 hours, when the dilatation is less than 0.5 centimeters, you will say it's a protracted active phase. Means there is a little bit of dilatation, but it's not what you anticipate. Now, why the study was, why they said you can allow these patients to continue in labor is because they've seen that a slow but progressive active phase of dilatation, it dilates that, it shows that even after 4 hours, these patients ultimately given time, many of them will dilate. So there is no need to hurry up and do a cesarean section, provided the mother and the baby is important. That's a caveat that you have to use. If the maternal condition and the fetal conditions are normal, if the patient is showing some amount of progress, there is no need to deliver her immediately. That is some take-home message that you have to follow. So for acute phase arrest, so that means after 6 hours of 6 centimeters of dilatation, when do you say there is an arrest? This slide is important. All of you must know. You will say there's an arrest in active phase if the person has reached 6 centimeters of dilatation. You've done an artificial rupture of membranes. You started an oxytocin drip. In spite of oxytocin drip with good uterine contraction for 4 hours, if the patient does not, either the head does not descend or the cervix does not dilate, you will say it's an arrest disorder. Suppose the contractions are not sufficient, then you will have to give at least 6 hours in ineffective contractions. And after 6 hours of ARM and oxytocin and the patient does not progress, then you will say it's an active phase arrest. Now, whenever you say an active phase arrest, I said labor itself, you have to think of 3 things: the power, the passenger, and the passage. So what should you do whenever a person has reached one particular stage and there is no further progress? You must identify 2 things. One is the contractions adequate? So for you to assess contractions, normally all of us, you would use only an external tokometer. You use your probe, and then you see what is the contraction, and you place your hand over the abdomen and see how long the contraction is lasting. Is it lasting for 40 or 45 seconds? But if you have all facilities, then you can put in an intrauterine pressure catheter and see, document, and then see. Ideally, for you to see if the contractions are adequate, in 10 minutes, you should be getting at least 200 mont video units. Contractions should be present. That means your contractions is adequate. Now, the other thing that you must see is you must assess the pelvis. Now, whenever you do an assessment of the pelvis, you normally do a Manroker-Muller's method, and that only assesses CPD at the inlet, because many often you're not able to assess the mid-pelvic cavity. Mid-pelvic cavity contraction is most often discovered only in the second stage of labor, when the head descends down up to the ischial spines, and then it doesn't descend any further. Then most often it's a mid-pelvic contraction. So whenever you have mid-pelvic contraction, the things to identify is, will you have a spines? Is it prominent? Is it a converging type of line? And is the head jammed there? So you must assess. So before you think labors can be progressed further, you must see that the contractions are adequate. You must look for it, start a syntosal drift, and assess what's happening. And you must assess is the pelvis adequate. If both are adequate, then only you can continue labor further. Okay. So and in spite of continuing labor with good uterine contraction, if the patient doesn't progress any further, then you will say it's an active phase arrest. Now, what about the second stage? Now, second stage is that they say there are two phases. After you said second stage is from full cervical dilatation until the patient delivers. But what happens is the cervix might be fully dilated at 0 station. So you have two stages. One is the passive phase, and then again is an active phase. Passive phase is the time taken for the head to descend down, and then it should come down to at least +2 station. Only after that the patient will start having the bearing down pains. So as soon as the cervix dilate, one important thing that you should do is don't ask the patient to stay in immediately. You have to wait until the head comes down further, and only when the head is reached up to the lower level +2 station or so, that is the time when you ask her to bear down. Okay. So now prolonged stage. Now most of us advise epidural. Most of the patients also ask for epidural. So after this epidural usage, they've seen that you have to give a longer time for these patients in second stage of labor. And they said, if it's a primary gravida, initially it was 2 hours for a primary and 1 hour for a multi. After full cervical dilatation, if they did not progress any further, then you say it's a second stage arrest or a prolonged second stage. But now they said you have to give 1 more hour. That is 3 hours for a multi, for a primary, and 2 hours for a multi, to say that's a prolonged second stage. Because if they are on epidural, you have to give 1 more hour. So that means after full cervical dilatation, you wait for, and the patient is getting epidural, you have to wait for 4 hours. And then only if she doesn't deliver, you would say prolonged second stage, then you have to intervene. In the case of a multi, you have to wait for at least 3 hours in the case of an epidural. Okay. So this is the recommendation. And again, this is a third recommendation, because sometimes often we will say a person is in latent phase. So in latent phase, that means up to 6 centimeters of dilatation. When we say it's failed induction, you're inducing labor. When we say it's a failed induction. Failed induction also means you've given her an oxytocin drip, you've done an artificial rupture of membranes, and for 18 hours after rupture of membranes and oxytocin, if a person, when you're inducing, if she does not enter into the active phase, then you will say it's a failed induction. So 3 important definitions that you must know. When do you say it's a failed induction? When do you say it's a prolonged second stage of labor? And when will you say it's an arrest in the active phase of labor? This is the ICOG recommendation, which all of you must know. Okay. Now, I said about oxytocin. How do you start an oxytocin drip? You have 2 types of drips. One is a low dose oxytocin, the other one is a high dose oxytocin. Low doses, you start with 1 million interaction units per minute. If it's in high dose, you start with 4 to 6 million interaction units per minute. And this is for, you will not know how much is 1 million interaction units. This, you can take this slide if you want to. Normally, ideally speaking, you should have an infusion pump. I think many centers will be having this infusion pump. So if you want to start a low dose oxytocin, 1 million interaction units per minute, so that means you add 5 units in your 500 ml of ringer lactate, and you have to give it 1.5 drops per minute. So that means 6 ml per hour. You set it at 6 ml per hour. If you set the infusion rate at 6 ml per hour, you can go back and see how the calculation is derived. if you start it at 6 ml per hour, that means 500 ml of RL, you're given 5 units of oxytocin, and you run it at 6 ml per hour, you will be delivering 1 million interaction unit per minute. Suppose you want to give a high dose, then we start it at 24 ml per hour. So whenever you start the drip, you must know this many ml per hour, how much of oxytocin is going. So that is very important because you can't give too much also. And it's ideally speaking, it's better that you have an infusion pump because patient will be moving her hand this side and that side. So infusion pump will administer the correct amount of oxytocin. And always remember, whenever a person's oxytocin drip, somebody should be sitting there and monitoring every contraction. In fact, every 30 minutes, you must see, for 10 minutes, you must be there and see how many contractions is getting and what is the amount of contraction, how long is it lasting. That is very, very important because oxytocin drip should only be increased every 20 to 30 minutes. You can't, you stay on there for 5 minutes, you're not getting contraction, you should not increase the drip. So the oxytocin drip should only be increased only after 20 or 30 minutes. Okay, now, so WHO has come up with certain guidelines. What all do you do to improve labor becoming better and to see that most of them deliver normally? Like I said, one is to start an oxygen drip, to do an ARM if the patient is not getting contractions. And it's very important, birth companion. See, that's one of doula is one of the most important because patients are left in labor all by themselves. They have nobody to be with them to see that they're hydrated, etc. So having a companion does a lot. Patient can be with them, talk to them, tell them, and give them some massage, etc. All this will help. And adequate hydration, this is another important that you have to do. So these are all the steps to promote normal delivery. Adequate hydration is very important. Ambulate the patient, because when they ambulate, what happens is the head is in a by gravity, the head comes down and it helps in dilatation. And again, use of intrapartum ultrasound. They say whenever, because what you say, you might think it's an occipital position, because malposition is one of the important reasons for prolonged labor. And malposition, you might say it's an occipital anterior, one might say it's transverse, one might say it's posterior. By use of intrapartum ultrasound, you will be able to very clearly say what is the position of the head and how long do you think a patient is going to deliver, because by itself, intrapartum ultrasound itself by itself is a big topic. So various angles, etc. But one of the most important angle that is says angle of progression of labor. Okay, so you can do that. I think in some other meeting they might talk about that. Okay, and if you are well versed, I think especially in the north, they do a lot of manual rotation of persons having a posterior precipitation. So all this will help in having a normal delivery. And these are some things that I thought that all of us must know. In fact, they say so much about doula care and so much about alternate positions and use of these birth balls. So when you use these birth ball, the pain becomes lesser, patient is able to tolerate, the pelvis becomes wider. And see all those, you must have these anti classes, you must involve the husband also, and he will be able to be with the patient and see that you can give some massage here, back passes. All this is to promote labor pains. Water birth, that also, even if you don't allow water birth, immersing in a hot tub gives a lot of pain relief. And see, this is a person who's doing a massage, comfort. So all this, patient the upright position. So all this should be done during labor to help her to have a normal delivery. So there are various techniques. It's not that most of us in all the institutions, patients are lying down flat on the labor board. That should not be done. They should be able to ambulate, have a birth companion, adequate hydration. All these are certain steps to see that labor is not prolonged, and many of them would have a normal delivery. Okay. And like I said, you must only advise delayed pushing, alternate birthing positions, and instrument delivery if necessary. One of the most important instruments in earlier days, we were using a lot of forceps and vacuum, but now it's come down drastically. At least vacuum is a very simple process, especially when they give an epidural. Patient will not have the urge to deliver. So all of us must be well versed in at least applying a vacuum. Okay. So to conclude, in a person who's having a prolonged labor, it is seen that by giving them a longer time, if they are still progressing, you will be able to achieve vaginal delivery. But important is you see that the mother and the baby are normal. If there's any fetal distress or you think the mother is having a problem with the pelvis, then maybe you should decide for a cesarean section. Okay, this is what I would like to say about prolonged labor. Now let's come to the very important topic, obstructed labor, because I'm sure many of you have not seen obstructed labor at all. And once you see it, you should be able to know what is obstructed labor. Now, obstructed labor is very common, especially in other parts of the country. In fact, especially in Africa, obstructed labor is very, very common. But many of us might come, many of our patients especially if they're not booked, they might come to you in labor and you might come across obstetric labor. So it's a very, very important thing because 8% of all maternal deaths are occurring because of obstetric labor. This is the statistics worldwide. But even in India, you see, it's around 5% of all maternal deaths are occurring because of obstetric labor. So it's a preventable cause of maternal mortality. So it's important that all of us know how to identify an obstetric labor and deliver them earlier. So what do you mean by obstructed labor? Obstructed labor is a case where a person, there is an obstruction to delivery. Either the head is too big, it's not going to the pelvis, or the pelvis is too small, there's an obstruction to labor, and without any further resistance, she will not be able to deliver. Now, as students, we were told this proverb: the sun should not set twice on a laboring woman. So it's a widely recognized, African proverb. And it says if labor lasts longer than 44 hours, you think something is dangerous. So it's just an alert. We don't, because the guidelines have changed, we just an alert. If the patient is in labor for a long time, then we must identify what exactly is wrong. So like I said, obstructed labor occurs when there's any mechanical cause which is preventing descent of the head, and in spite of good uterine contraction, is not able to deliver. So let's see what are all the reasons why a person has obstructed labor. Most important, CPD. CPD is not the same as contracted pelvis. Contracted pelvis is by itself a very important cause. But what is CPD? The pelvis is okay, but by some reason the baby is large. So it might be because of malposition, because a larger diameter is getting into the pelvis. You have malpresentation, like a brow presentation, or a occipital posterior presentation, where a larger diameter enters into the pelvis. As a result, a CPD occurs. Once a CPD doesn't mean that every time the same CPD should occur. And the second one, you can have a contracted pelvis. Means the pelvis is small gynecoid pelvis or an andro type of pelvis. These are the reasons why you have an obstructed labor, because of faults in the pelvis. Or there should be some soft tissue abnormality like a fibroid or a uterine anomaly. She might be having a rudimentary hole which is sitting in the pelvis, or she could be having a big fibroid which is sitting in the pelvis and preventing the head from descending down. Or there could be cervical dystocia, which occurs following a Farthingale surgery, cervical amputation, where the cervix head comes down, but the cervix just fails to dilate at all. Or there could be macrosomia, fetal macrosomia, or hydrocephalus. Hydrocephalus, we don't, it's very rare. It was there earlier on when people did not have frequent antenatal checkup or ultrasound. Now, every visit, in fact, patient seems to have an ultrasound. So it's very rare to not diagnose a hydrocephalus earlier. Okay. So what is the pathology? Why do you have an obstructed labor? So what happens is there's an obstruction. So the head is not able to descend down. She's getting very good contractions. So what happens? The upper segment starts contracting, the lower segment dilates. The lower segment keeps on dilating. The upper segment goes on contracting. So normally you have a separation between the upper segment and the lower segment. That's known as a physiological retraction ring. But when there is no descent, it becomes pathological, and we have a Bandrell's ring which forms between the upper segment and the lower segment. And this Bandrell's ring starts climbing towards the umbilicus. You say it rapidly rises capillate. If you don't intervene at that time, the lower segment cannot expand any further and it gives way, and you have a rupture uterus. So you should not allow a person with a Bandrell's ring to continue any further. It is time that you intervene. But first is recognition of the Bandrell's ring. How does a Bandrell's? So this is what is the a diagrammatic picture. So this is your lower segment. And this lower segment, the upper part is showing what happens in normal labor, but this is the lower segment. That is not the lower segment, maybe around 5 to 7 centimeters or 8 centimeters it may dilate. But after that, it's mainly it doesn't dilate so much. You just look here. There's an elongated and thinned out lower segment whenever this is an obstructed labor. The upper segment is becoming thicker and smaller. The lower segment has really stretched so much. It is not only elongated, it's also stretched. It becomes edematous bladder. So if you don't intervene at this stage, it will end up having a rupture uterus. This is how a rupture uterus looks like. This picture I've taken from the neck. This is a typical appearance. See, the lower segment is stretched so much. This is even better. This the entire thing is the lower segment, and this is a thinned out lower segment. So the Bandrell's ring keeps on increasing. So whenever you have a stretched out lower segment, there are other differential diagnoses that you must think out. Suppose you're seeing the patient for the first time. One of the most important differential diagnoses that you must think out is it a distended bladder? So all cases with stretched out lower segment or a suprapubic bulge. In other words, you will say it's a suprapubic bulge. It's not an obstructed labor. So you must immediately put in a catheter and see. After putting in the catheter, if this the bulge doesn't disappear, that means 100% is only because of a distended lower uterine segment. You identify, you just wait for some more time, and then you see this part will keep on rising. This depression that you see here moves here, moves here, moves here. That means it's an obstructed labor, and that is a banded ring. Once you identify a ring like that, that means an obstruction. You have to terminate the pregnancy immediately. Okay, so this is what happens. You have a banded ring. This is a normal shape of the abdomen. You have a depression between the upper segment and the lower segment. If you do not do anything, this is a postmortem appearance. See, this is the upper segment. This is the lower segment from here to here to stretch, and it rupture uterus, and the baby is there. Okay. So how do you identify? Clinical on abdominal examination, you have a stretched out lower segment and a thickened upper segment, a ring between the two. And the ring is not exactly in the center, it's more circumferential. And you have a tachycardia, round ligament will become very prominent. You might have fetal tachycardia, you might have maternal tachycardia. When you do a vaginal examination, you have a fully dilated cervix and you have a huge caput. The head might be, you might think the head is lower down, maybe at +1 station, but it's not the head which is there, it is the entire caput and the molding which is there. So you might have a huge caput. Whenever you have a huge caput, you might misdiagnose and say the head is at lower level. No. So always do an abdominal examination. If the fetal pole is still palpable, if the head is still palpable per abdomen, then what you're seeing is the huge caput only. So you should not mistake and say head has come down, I'll put a forceps. That should not be done, because always before applying any instrument, if you think the head is low down, always go back and see, is the head palpable per abdomen? Are you able to feel the synsput and the occiput? If the head is palpable, that means it's only a caput. Okay, so on vaginal exam, you may make out a huge caput and you might have third degree molding. Third degree molding means even when you depress, there's an overlapping of bones. Even after depressing the two bones, the molding doesn't come back. When the molding might be more than 4 or 5 millimeters. And the head appears jammed in the cavity. It appears that it's dry labor. There is no space at all between your finger and the head. That means it's a CPD is there. And because of repeated, you might also have vulval edema, cervix might become edematous, bladder might be distended, you might also have hematuria. These are all some points to focus that there is an evidence of an obstructed labor. So what happens if you don't do anything at that time? The uterus might rupture. If it's a prolonged labor, she might go in for sepsis. Obstetric fistula. In fact, in African countries, obstetric labor, the incidence almost around, they say it could be even around 30 to 40%. And because of obstetric labor, one of the most important, the type of pelvis that they have is normally a platypelvic pelvis. In a platypelvic pelvis, the AP diameter is very short. So the head is jammed and it presses upon the bladder. So more chance of BVF and obstetric fistula. That's very, very common. Obstetric palsy, rupture uterus, these are some complications which can happen as far as the mother is concerned. And as far as the fetus is there, increased chance of maternal perinatal mortality. You could have an intracranial injury, sepsis for the baby, cerebral palsy, and the baby, even if delivered, can give rise to delayed milestone. So, like I said, prevention is, you must be able to identify at the beginning, is this person having a normal pelvis? Can she be given a vaginal delivery? And if you recognize something is wrong, that is where the partogram helps. So if you think there's a delay, then you have to immediately refer to a higher center. And if you identify in your practice, if you identify a banded ring, you must immediately rule out, see, is the pelvis is okay, like I said, all these signs. And then if there's any problem, you have to intervene immediately. Okay, so there, speed is what is very important whenever you have a banded ring. So how do you manage? You must immediately simultaneously resuscitate the patient and take her up for a cesarean section. There is no place of instrumental delivery, even if you think the head is down. You must always go in only for a cesarean section. There is no place for an instrumental delivery. Only place for destructive surgery in the case of obstetric labor is when you think it is because of hydrocephalus, the head is still on top. Then you can put in a needle and drain out. But however, there is no place for any other destructive surgery like a craniotomy, etc. should not be done. Whenever you have a destructive labor, no instrument delivery, no destructive surgery. Okay. So I just want to tell about two important or very simple procedures that we can do whenever there's an obstetric labor. One is the cervical dystocia. One of the most important reasons for cervical dystocia, I already told you, it could be, normally a person could have a cervical dystocia or following procedure on the cervix like an amputation of the cervix or a farcical surgery. In which case the cervix is not fully dilated, but you almost see the head, which is there. So in such cases, you could do what is known as a Duverson's incision. Place 2 or 3 your ovum forceps, and then cut the cervix in between around. You could have it at 3 o'clock position, 7 o'clock position. Avoid making incision here 3 and 9 because you might injure the vessels. So make it around 7 o'clock position, 4 o'clock position. That is the time when you would, or you could even do 3 or 4 incisions also could be done to dilate the cervix. But you must be very careful that you do a guarded cut, because if your incision, if it extends and the head comes out very rapidly, then you can go up, your incision can extend up and can become a colporexis, and you may have to do a laparotomy. So you should be very careful when you do this Duverson's incision, but it's a worthwhile incision that all of your man, suppose it's already 7 centimeters, the cervix is not dilated, then maybe you could use this Duverson's incision. And the other thing that is practiced outside, especially in the African countries, is your symphysiotomy. So there, what happens is you make an incision in the pubic symphysis, so the pubis just opens out and the head delivers. So you put in a catheter, guard the bladder, and you just make an incision. You put your finger inside and protect the bladder, and then you make an incision over the arcuate ligament, and then the pubic symphysis separates. Okay, that can be done, but you should be very careful after this. What is the procedure? After you make the incision, the pubic symphysis separates and the epididymis delivers, the baby will be able to come out. You only do it when you don't have a recourse to cesarean section. Okay. And after this, what happens is patient will be having difficulty in walking. So you must strap the pelvis and see that you don't ambulate her for at least for 48 hours. You must put in the catheter, and the patient should be under catheter for at least 24 to 48 hours. Okay. So this is what you do in an obstructed labor. Okay. So giving birth itself should not be a death sentence to a person or a life sentence. She should not, after delivery, she should not have any major problems like a baby wave or a morbidity which causes her to become an outcast in pregnancy. You should see that she delivers normally. It's important that you identify prolonged labor. It's important that you identify obstructed labor and intervene at the correct times. So to just conclude, you must know what is prolonged labor. You must know the ICOG definition for labor active phase arrest. You must know when is prolonged second stage of arrest, and you must know when is failed induction. So these 3 definitions, all of you must know. You must know when is obstructed labor, what are the causes for obstructed labor, how do you identify abdominally suspect it's an obstructed labor, what are the vaginal examinations in the case of obstructed labor, and what are the interventions that you will do. And basically, what are the interventions that is permissible, which is easy, which does not have major problems to the patient. Thank you so much for your patient hearing. If there's any questions, I would like to answer.
Thank you, Dr. Chitra. That was amazing. And you took us in a very short space of time to so many different complications and so many different remedies. Many of these treatments like Duverson's injection, which you mentioned, obviously are something which we don't see very commonly in our clinical practice, but in a small nursing home or in the periphery, in primary health centers, sometimes these can be life-saving. So thank you very much for sharing your knowledge and your expertise with us. It was amazing to listen to you. I hand over back to the organizer. Dr. Hafizur, are you there? Can you please take it forward?
Yes, sir. Yes, sir. Thank you so much, sir, for your comments. And thank you, Dr. Chitra, madam, for your excellent demonstration, excellent presentation on these 2 important topics. And I'm sure it's going to be very much helpful for the students. And it will be in the ICOG website as well. And the student who have missed it can go in future. Thank you so much for your excellent presentation. Now moving on to the next, another important sessions, that is on case discussion. Today's case discussion is on fetal growth restriction. And as usual, the student presents the case, and we have the galaxy of expert faculties from all over the India. Now the students are Dr. Hiba Rizwan and Dr. Rehmat Ali. Both are third-year postgraduate student from Silchar Medical College, and they have been very nicely guided by their faculties. Dr. Pranay Nath, professor and head of the department of Obstetrics and Gynecology at Silchar Medical College, and Dr. Fuzail Ahmed. Now, I'd like to take over our faculties, and Dr. Ashish Mukhopadhyay is there, although he's in Birth Conclave in Lucknow. So, other than Dr. Ashish Mukhopadhyay, we have Dr. Padmaja Wai, Madam. She is Professor and Head at Seth GS Medical College and KEM Hospital, Mumbai. Welcome, Ma'am, Padmaja, Ma'am. Then we have Dr. Upma Saxena. Madam is Professor of Obstetrics and Gynecology at VMC and Safdarjung Hospital, New Delhi. We have Dr. Jasmina Begum. She is Associate Professor of Obstetrics and Gynecology at AIIMS, Bhubaneswar. Welcome, Dr. Jasmina. And the last but not the least, Dr. B.M. Rupakala. Madam is Professor and Head at Rajeshwari Medical College and Hospital at Bangalore, Karnataka. So I'd like to request the students, Dr. Hiba and Dr. Rahmat Ali, to share their presentation, and at the same time, I would like to request the faculties, the examiners, to take over and conduct their case. Over to you, faculties.
Thank you, Dr. Hafizur. Yes, I'm there, very much there. Although I'm in Lucknow, but I'm always there in this case presentation also. So I think I will invite the students now. The students are Dr. Hiba and Dr. Rahmat.
Good afternoon,
Guided by
sir.
their coordinating faculties, Dr. Pranay Nath. Hello.
Yeah,
we can hear
Dr.
you, sir.
Ashish, good morning. Good morning.
Good morning. Good morning. Yes.
Yeah,
Welcome, sir.
Yeah.
Good morning, Pranay, sir.
Yes, Dr.
Good morning.
Pranay
Good
Nath
morning,
is
Dr.
there.
Hafiz.
Dr. Hafiz,
And
Yeah,
Dr.
we
Fuzail
decide
Ahmed
to-
is there.
Yes, ma'am.
Yes, I would like to
Hafiz,
request
Yes, ma'am.
the students to present, share
first
their
and
screen,
all the
please. Yes.
questions will be later.
Ma'am, I think it will be better if the students can finish up their presentation, and then
so
please go
it
back
will
to
be
slide
decided
one.
later. Okay, thank you.
Yes, ma'am.
Thank
You can go back to from slide one and then go and crossing the history. And
Thank you.
Yeah, sir.
Okay.
That's a better idea, sir.
Yeah, thank you.
that will be better, because then they will be able to finish up their presentation and the flow will be maintained. There may be a little bit of problem if you are there caught in between the presentation. So please, once they finish, then you can come back to the slide one and then continue with your process. Over to you,
Yes,
Dr.
sir. Good
Hiba and
afternoon,
Dr.
sir.
Ahmed
Is it
and all the
visible, sir?
examiners.
We have shared the case presentation, sir.
Yeah, we can see it.
Audible, visible. Go ahead.
Shall we start, sir?
Students and
Yeah,
students,
yeah.
yeah. Please go ahead.
Hiba, just move your slides. They are moving. Just check, and you
Okay,
can.
okay.
Yeah, it's moving. Yeah, it's fine.
Okay, ma'am. Thank you, ma'am. Good afternoon, respected teachers and esteemed online viewers. I am Dr. Hiba Rizwan, and along with me is my batchmate,
Muhammad Rahmat Ali.
We are third year postgraduate student from Department of Obstetrics and Gynecology at Silchar Medical College and Hospital, Assam. And today we are privileged to present a case on fetal growth restriction. Our coordinating faculty for today's session is Professor Dr. Pranay Nasser, who is a professor and head of department, and Dr. Fuzail Ahmed sir, who is an assistant professor from our department. We will be presenting a case of Mrs. PD. She's 35-year-old homemaker. She has completed her education till 10th standard. Her husband is Mr. Rezi, 38-year-old. The couple belong to Hindu religion and resides at Katigora, Kachar, Assam, which is around 20 kilometers from our hospital. Patient was admitted on 22nd of February 2026 with LMP of 12th of June 2025, and which makes her EDD 19th of March 2026. Chief complaint, the patient presented to our OPD with the chief complaint of reduced fetal movement for 1 day along with an amenorrhea of 8.5 months. History of present illness. The patient was referred from a private hospital with a complaint of reduced fetal movement for past 1 day. She reports a decrease in both frequency as well as intensity of fetal movement compared to her usual pattern. The movements are not adequately perceived even after meal or rest, and she has perceived only 2 to 3 fetal movement in last 24 hours. She gave a history of elevated blood pressure, which was detected 2 weeks prior on a routine antenatal checkup, for which she was started on oral antihypertensive medication and was also informed of a fetal growth lag on ultrasound by her attending doctor at that time. There was no complaint of headache, vomiting, or epigastric pain, or any visual disturbance. It was not associated with pain, abdomen, bleeding, or leaking per vagina. In menstrual history, the age of patient has attained her menarche at 13 years of age. The past cycles of the patient were regular. It was 28-day cycle with normal flow. She used to use 1 to 2 pads per day, and it was not associated with pain or any passage of clots. Her LMP is 12th of June 2025, and she's sure of her LMP as cycles were regular. The patient was married 2.5 years back, and it was a non-consanguineous marriage. On obstructed history, she is a primi gravida. Her last menstrual period was 12th of June 2025, which makes her EDD 19th of March 2026 as per Niggles formula. And gestational age at the time of presentation was 36 weeks, 3 days. Present obstructed history is the present pregnancy is a spontaneous conception. She came to know about this pregnancy by a positive urine pregnancy test kit, which was done at home after 10 days of missed period. Patient was booked at a private clinic at 2 months of amenorrhea and has been compliant with her folic acid, iron, and calcium throughout her pregnancy. Quickening was felt at 5 months, and she has received 2 doses of TD vaccine, which was 1 month apart, and are given at 5th month and 4th and 5th month. Antenatal period of this pregnancy was uneventful in the first and second trimester with normal investigation and ultrasonography. At 8 months of her gestation, she was detected to have a raised blood pressure, and for which she was started on oral antihypertensive medication. USG was done at that time, and it showed a fetal growth lag, which was reported to her at that time by her attending doctor. At 36 weeks, 3 days, she presented with reduced fetal movement for 1 day to her private clinic, and for which she was referred to our center for further management. There was no history of pain, abdomen, bleeding, or leaking per vagina throughout this pregnancy, and no history of headache, blurring of vision, epigastric pain, swelling of limb, or any sudden weight gain. There is no history of fever with rash or any radiation exposure. In past medical history, there is no history of diabetes, hypertension, chronic kidney disease, heart disease, or any other significant medical history in patient, and there was no significant surgical history. In family history, the patient has no family history of congenital anomaly, twinning, hypertension, or a diabetes mellitus, or any other significant family history. In personal history, the appetite of the patient was good, sleep was adequate, bowel and bladder habits were regular, there was no history of any substance abuse, there was no history of excessive caffeine intake or any vigorous exercise done, and no known allergy to any drug or substance. In dietary history, as per her 24-hour recourse method, the total calorie intake calculated was 2,600 kilocalorie per day, and total protein intake was 70 gram per day. In contraceptive history, the patient has not given any history of using any contraceptive methods. In socioeconomic history, the head of the family is her husband. Education of husband is he has studied till 12th standard, and his occupation was driver. So it is a semi-skilled worker. Total per capita income per month is 25,000. So they belong to lower middle socioeconomic class as per modified Kuppuswamy scale. She lives in a Pakka house and with a nuclear family. Now, the further lecture will be carried out by a batchmate.
On general examination, the patient was conscious, oriented to time, place, and person. She was well nourished and moderately built. Her height was 156 cm with a pre-pregnancy weight of 70 kg that makes her pre-pregnancy BMI of 28.8 kg per meter square. Her present weight was 78 kg that makes her total weight gain of 8 kg. On general physical examination, pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal were absent. Her vitals were BP of 150 by 90 mm of mercury in the right arm in supine position. Her pulse rate was 88 beats per minute, that was regular and normal in volume. She was afebrile and her respiratory rate was 14 per minute, that was regular. On breast examination, breasts are bilaterally symmetrical Nipples were everted to no cracks. Areola are pigmented and healthy. On systemic examination, no significant finding in systemic examination. On obstetric examination, on inspection, abdomen was uniformly enlarged, longitudinally ovoid, and skin were healthy. Umbilicus was flat and central. The stria gravidarum and linea nigra was present. There was no abdominal scar or dilated veins. On palpation, symphysiofundal height was 33 cm. The flanks was not full. Her fundal height was 32 weeks and abdominal girth was 34 inches. On fundal grip, a soft, broad, non-volatile structure felt that was suggestive of breech. On lateral grip, a knob-like structure on the right side of patient's abdomen was felt that is suggestive of limbs. A smooth, curved, hard structure was felt on the left side of abdomen that was suggestive of back. On first pelvic grip, a smooth, hard, ballotable structure was felt that is suggestive of head. On second pelvic grips, fingers were converging that suggests the fetal head was not engaged. On auscultation, fetal heart rate was 142 per minute that was regular, hard over the left spino-umbilical line. The summary of our case is Mrs. PD, a 35-year-old primi gravida, married for 2.5 years, coming from a lower middle socioeconomic status. She was referred from a private clinic and admitted on 22nd of February 2026 at 36 weeks, 3 days of gestation with chief complaint of reduced fetal movement for 1 day. Her menstrual cycle were regular earlier and her LMP was on 12th of June 2025 that makes her EDD 19th of March 2026. She had regular antenatal checkups and was compliant with iron folic acid, calcium supplements, and TD immunization. At 8 months of amenorrhea, she was found to have raised blood pressure and started on oral antihypertensive, and USG showed a fetal growth lag. So on examination, her BMI was 28.8 kg per meter square with a weight gain of 8 kg. Her BP was 150 by 90 mm of mercury with no other significant finding in general and systemic examination. On obstetric examination, a single live fetus in cephalic presentation that was corresponding to 32 weeks, which is 4 weeks less than the period of gestation, and the FHR was regular with adequate glycol. So the provisional diagnosis of our case is 35 years elderly primi gravida at 36 weeks, 3 days of gestation with a single live fetus in cephalic presentation with gestational hypertension and small for gestation with reduced fetal movement.
Thank you to my students. So your diagnosis has two components. One is small for gestational age, another is gestational hypertension. Now I'm delighted with faculty Dr. Padmaja and Dr. Upma to kindly take up the history part, crossing, and Dr. Jasmina and Dr. Rupekha to take up the examination part. Thank you. Dr. Padmaja first.
Dr. Padmaja, you are around? Madam, you are muted, madam. Madam, you are muted.
Yeah, now
Dr. Padmaja, please unmute yourself.
So, good job, Rizwana and Rahmat. Now, some suggestions. In the first slide, now you have said case presentation. So, on what? Normally, in exams, we should not be giving the diagnosis right in the beginning. That is first thing. Second thing is there should not be any short forms of EDD, LMP, etc. in the exam. Then 2 to 3 movements in 24 hours. So what I would like to know, now this is a question, in IUFD, do we get movements?
As a patient profile, your comment about writing EDD on the patient profile, should it be written over here or should it go to the, obstetric history or menstrual history, something like that?
Be in a short form, that's all. Yeah. But the question is, in an intrauterine fetal death, do we get movements?
No, ma'am, we don't get any movements.
Are you sure? Why do we not get movements?
Sometimes patient may perceive movement, but
that would be, ma'am, like patient will falsely perceive movement. That is not the fetal movement, ma'am, actually.
So what is it?
So if there is movement, ma'am, sometimes bowel movement, patient will perceive bowel movement as fetal movement, like she will falsely perceive it, but it will be very slow, so she will be confused, ma'am.
Acha. One thing is, baby is floating in the liquor, right?
Yes, ma'am, liquor.
Yes, ma'am.
So because of patient's own movements, the baby may move inside the liquor. It is not baby's body movements, not movement initiated by the baby, but a patient can still move. So this is extremely what you call urgent case, because she has perceived only 2 to 3 movements in 24 hours. Now, what else I would have liked you to say is that when the doctor BP at that clinic 34 weeks,
some disturbance is there. I can be mute.
I know somebody is speaking. Okay, shall I go on?
Yeah. No, I think they have muted.
So when the private consultant detected blood pressure to be high and started oral therapy, was any other intervention done like your CTG or anything, or no intervention was done by the doctor? Because the doctor has he has assured something, which is another thing. That we would like to know as managing the while managing the case. And next is, you put somewhere in the 8th month slide, radiation, no exposure to radiation. So I would rather not put it at the 8th month, radiation, because 8th month radiation, then your question is going to be, which are the most affected parts in 8th month radiation? Okay. And what is the type of radiation, etc., which is normally there, then how many rads, etc. So 8th month के इसमें कभी आप radiation मत डालिए. वो radiation can happen during whole pregnancy. So it probably should not be there in that. Then in the family history, you have said no history of anomalies. Which are the familial anomalies I would like to know from you?
Familial anomaly. Ma'am, patient may have some congenital anomalies like any trisomies, like trisomy 13, 18, or Down syndrome.
Correct. Are they familial?
If there is a history of having a baby with a congenital anomaly in the family, the risk of having is increased in the risk will increase in the mother, ma'am.
Which type of anomalies?
Ma'am, chromosomal anomalies.
Which chromosomal anomalies again? Because nowadays, if there is a family history of chromosomal anomalies, then a lot of radiologists and fetal medicine specialists send patients for extremely costly investigations. So I would like to know which anomalies should we be considering in this? Okay, that is another part you may consider. Then you have written no history of vigorous exercises. So the question the next question comes is, what is permissible exercise, what is vigorous exercise, etc. So that is one caution to you. You have not mentioned what type of diet patient takes, whether she is vegetarian, mixed diet, or non-vegetarian. At least I didn't hear.
Oh, she was taking a mixed diet, ma'am.
Okay. Then you have said 25,000 per capita is lower socioeconomic status. So their family members, if there are 2 family members, it is 50,000 per month. That socioeconomic status 50,000 per month is lower socioeconomic status, I don't know.
That was for, ma'am, it was, sorry, ma'am, it was our mistake, ma'am. It was not per capita, it was the whole family income, ma'am.
Whole family income, na? That is
Yes,
it.
Whole family.
Then at this gestation, when you examine the patient's breast, do you expect cracks on nipples?
Ma'am, we don't, at this late of pregnancy, we don't expect it, ma'am, but
In antenatal
There may be
period, we don't
detected
expect
nipple.
cracks on nipples.
So why do you do it? Why do you do the antenatal examination?
Yeah, that is
ma'am,
important.
actually, this patient was not our follow-up case. She was booked outside somewhere. So it is advisable to do breast examination at least once in pregnancy. That's why we did it in our patient, ma'am.
That is fine, but cracks on nipples is something that you cannot be, means that's something which is extremely abnormal to have in antepartum period when the patient has never fed the child. Okay?
Okay.
Okay. So this much about this examination. Then on per abdominal examination, when you mentioned all the grips and all that, because our plan is going to be, we will come to the plan later, but a good idea to have a complete per abdominal examination when we also should mention whether the head is flexed or not, because these are the ordinary maneuvers which we do and we come to know
Yes,
all this
yes,
information. Huh?
Okay. Okay.
You have somewhere said with normal liquor.
Adequate
ma'am.
liquor,
Yes,
yes, ma'am.
Adequate liquor. On clinical examination, when there is growth restricted baby with 4 weeks lag, saying adequate liquor is slightly, it may not really go with clinical examination. Anyway, that we will see as the discussion goes by. So these are my suggestions. Okay.
Okay.
Okay, ma'am. Thank you so much.
Thank
ma'am.
you.
So can I start? No. Can you tell Hiba what was any high risk in this patient for FGR?
Ma'am, in
It
this,
was found that the baby was small. So any high risks in the history or in the examination which suggested that, yeah, maybe growth restricted?
Ma'am, in our patient, ma'am, there are high risk, ma'am. As the age of the patient is 35-year-old, that is itself is a high risk, and primigravida also is a minor risk factor. Then, ma'am, our patient had a high BP at later in pregnancy, which is also a risk factor for IUGR, ma'am.
her BMI was also raised, ma'am.
Yes, ma'am.
So she was okay.
She was
It was
overweight.
okay. 28 BMI. She was overweight. She was not obese. Okay. Any other
Yes,
high
Yes, ma'am.
risk? What about the weight gain? How much should be the weight gain during pregnancy? What is
Ma'am,
the ideal weight
should
gain?
ideal gain for a normal BMI is, ma'am, around 11.5, 11 to
So
12. ma'am.
how is it distributed? This weight gain is distributed how? How much is put in each trimester?
Ma'am, around 4 kg is in the first half of the pregnancy and 8 kgs in the later half of the pregnancy, ma'am.
Usually in first trimester they would put on weight because of the nausea vomiting on pregnancy. So
Yes,
usually
ma'am.
we say 5 plus 5. Okay. So usually one first trimester is 1
Okay,
kg.
ma'am.
Second trimester 5 kg. And what is the ideal
Yes,
in
ma'am.
the how much should be the weight gain? Ideal weight gain if you're doing, because every time patient comes for antenatal checkup we are doing weight gain. So what is the ideal weight gain when you say it's optimal?
Ma'am,
Per week or in 2 weeks?
optimal, ma'am, ma'am, in around for a week, it should be in 2 weeks, ma'am. It should be around ma'am, it is around more than 2 kgs in 2 weeks. In 2
So
months,
it's
ma'am.
around 1 kg we say in 2 weeks or around 1 pound a week. Okay,
Yes,
half kg,
ma'am.
half kg,
Yes,
half
ma'am.
kg.
So you
So
should
that
know
is
what is
Half kg,
abnormal
ma'am.
weight gain.
earlier we were putting a lot of emphasis on weight gain. Still now we are more relying on. And how do you take symphyzofundal height? You have taken symphyzofundal height, which was
Yes, ma'am.
32 centimeters. So from what POG you start taking
Yes,
your
ma'am.
symphyzofundal height? After what POG? Period of gestation, and why?
Ma'am, we start to measure symphysis height from 26 weeks of gestation, and we can measure the
24,
symphysis
around
height
24.
24.
24 weeks of gestation.
And
Ma'am, to measure symphysis height up to
Up to what
30,
weeks?
8 weeks of gestation.
36.
Up to 30?
32. Up to
You can-
32.
30,
Yeah.
38
And
weeks
what
of
are the
gestation.
fallacies?
How do you take it? First of all, how to take it?
Ma'am, to measure symphysis height, first of
You
all,
had taken, how
we will
you
ask
did
the
it? Can you
patient to.
explain it to me?
Yes, ma'am. To measure symphysis height, we will ask the patient to empty her bladder, ma'am. And then in supine position, ma'am, with leg straight, ma'am, we will first measure the.
Of legs?
No, ma'am, straight, ma'am.
Okay.
Okay.
Ma'am, we will first measure the symphysis fundal height, ma'am, and then we will mark there. And then
Can you just mark it like that? Uterus is not straight.
See, what is the point you take? That's what my
Oh,
is
ma'am.
asking. From
Your
where to
First of
where?
all,
dextro rotated. You have to correct the
Yes,
dextro rotation. So that is the most
Yes,
important. So how
yes,
you
ma'am.
will correct the dextro
And
rotate,
then
then you will.
giving,
And how will you start? From below
and
or from
from
above?
there,
Above, down, or below, up? How do your hand should move?
From your fixed
ma'am,
point.
above
Which is the
to
fixed
down,
point?
ma'am.
Always you should move more, and after you have corrected the dextro rotation, then you start and then
Okay,
you
ma'am.
mark. And how do you measure
Yes,
in
ma'am.
centimeters or inches, and how should be your inchy tape? The measuring tape?
Ma'am, our marking will be downside, ma'am. We should not see the marking through.
So if you are
and-
measuring in centimeter, then which should be up? So other side.
Inches would be up, ma'am.
Yes,
So why you want that?
Ma'am, it will, we want to, ma'am, error, because if we are seeing, then we will, there
You will be biased.
ma'am,
Biased.
yes,
So
ma'am.
to remove the subjective bias, you want to do it that way. And when will you say the growth is baby is small? At what should be the discrepancy between the period of gestation and your symphyso-fundal height? When you will
Ma'am,
say
it should be around, ma'am, 4 weeks of discrepancy, ma'am, between fundal height and
that is in weeks. I'm talking about symphyso-fundal height. There are two things. One, you are just
Yes, ma'am.
measuring the uterine
if
height,
it is less than
and other is
less-
symphyso-fundal height in centimeter. So both
Yes,
are
ma'am.
different. So
Yes,
there are
ma'am.
two
if it is less
values.
than 3 centimeter, ma'am, then
So for
we will suspect.
symphyso-fundal height is 3 centimeters. So your
Yes,
patient
ma'am.
was 36 weeks. So it should have been 36 centimeters. Yours was 33
Yes, ma'am.
centimeters.
Yes,
And
ma'am.
when you see the fundal height, 2 weeks you start suspecting, and 4 weeks you make a diagnosis that your baby is small. So what we are making a diagnosis, just the baby is small. That is your clinical way of knowing, diagnosing. Hai na?
Yes,
Because
ma'am.
high risk, which
yes,
we
ma'am.
suspect, then we subject them to further investigations.
Yes.
Yes,
Okay.
ma'am.
So in your case, have you just measured once the symphyso-fundal height, right?
Yes, ma'am.
So just the measurement once of symphyso-fundal height is not diagnostic. You only suspect FGR when you chart it, isn't it?
Yes, ma'am.
So symphyso-fundal height should be measured every visit.
Yes, ma'am.
So
And you
as
chart
you
it
have
in a
Doppler
graph.
chart, you should mark it, because
Only when it is less than the 10th centile for that gestational age, or when you do a serial plotting, the growth is static, or you see a downward growth, or even when you cross the centiles, then only you suspect FGR. Just one measurement of FGR does not indicate to you that it should be FGR.
So
Yes,
if we just see fundal height,
you-
the sensitivity is 30%.
Yes.
And if we plot, as madam said, then the sensitivity increases almost to 60 to 70%.
Yes,
So it's
ma'am.
always better to measure and to plot it. Then the sensitivity increases, your detection
Yes,
rate is
the plotting
increasing.
and the
You
growth
have the
curve is
growth
very,
chart.
very important. Very,
Grow
very
Growth
important.
UK charts, which are easily accessible,
Yes, ma'am.
freely accessible and free, where you take
Yes,
all
ma'am.
the variables like age, sex,
Correct. Yes.
weight,
Absolutely.
so
Yes, ma'am.
and also the ethnicity. So your charting becomes very well, and they are free and easily accessible. They are called as growth-related optical weight. That is UK
Yes, ma'am.
charts, easily available. So you can do that. Then only you can confirm when it is below your serial plotting, where it becomes either static or it crosses your centiles. That is important.
Okay.
Yes, Dr. Ruplek.
Yeah. Yes, sir.
Dr. Ruplek, yes.
Yes, sir.
A very good point raised by you.
Yeah.
You know, the students must realize that the
one single measurement is not enough.
Not a one-off diagnosis.
Yes,
it
sir.
cannot be based on one single fundal height measurement, one single fundal height measurement,
yes, sir.
one single ultrasound measurement.
Yes, sir.
It's a continuous process, and the growth has to be plotted on a curve, and this plot will give you the actual growth. Because
So
what
what-
measures
So
is
we are looking is at growth velocity.
yeah. No,
Yes, growth trajectory. It is called as growth trajectory. So it falls below the line or not is very, very important.
It has to be repeated and time-bound measurement of the growth. I mean, our ultrasound measures the size, and repeated plotting of this ultrasound at regular intervals will give you the growth. This
would be the easiest way clinically, sir, to suspect FGR, which everyone even in the rural areas can be done very easily.
Yeah, this is very cost effective. For low risk pregnancies, this is the best way to diagnose the baby is small. Clinical way, because everywhere ultrasounds are not available. So,
Dr. Hiba,
how about the assessment
just I
of
have
fetal
few
weight
questions.
clinically?
Yes, ma'am.
Dr. Hiba, I have few
Yes, ma'am.
questions. Can you go to
Yes,
second slide? Second slide.
Yes, ma'am. This one, ma'am.
Second, yeah. So, like, it's our standard teaching. Like, I just want to ask 8 months of amenorrhea, whether your patient is aware she's having pregnancy or not.
Ma'am, she is aware, ma'am.
Oh, okay. So when she's aware, it's better to write the 8 months of gestation instead of amenorrhea. Okay.
Oh, okay, ma'am.
So this is the standard way of teaching. What we teach is our MBBS and postgraduates, like history, like what you have written. Instead of amenorrhea, you can write gestation. Okay. And a few more things I have noticed, like history of present pregnancy. Somewhere you have written 8 months, somewhere you have written 36 weeks, 6 days. So either you make it uniform.
Oh, okay, ma'am.
Don't write 8 months somewhere. Don't somewhere you have written 36 weeks, 6 days. So make it uniform. Either you go with weeks or go with months.
I think it's history should be in patient's language only. 36
Yes,
weeks are diagnosis, not so. In
okay,
history,
then she can
it
go
should
with
be
8
always
months.
in patient's language. So it should be weeks,
Yes,
8 months.
Okay, ma'am.
Okay, मेरे को 8 महीने चढ़े. So always 8.
And
Yes, ma'am.
one more thing, like as you have clubbed trimester histories, so it
Yes,
has to be in
ma'am.
sequential order. Like whatever events happen in first trimester, you have to discard. It has to go in first trimester, second trimester, third trimester, but you have clubbed it. Okay, so it
Yes,
has to
ma'am.
sequential order because at the end,
Here they have written present obstetric. We usually say trimester wise, and we
Wise
split it
history.
into 3. First
Yes,
trimester,
yes,
second
yes.
trimester,
Because
third
at the end you have written fever with
trimester.
rash and drug
Radiation you
history.
have written last.
Radiation.
Yeah.
Yeah.
That should be in the first trimester.
That has to be in first trimester.
Oh,
Then
okay.
Better
one
write
more
it
thing.
trimester wise. First trimester,
Yes,
second
yes.
and third trimester.
And one more thing
how
that
did you-
as madam was asking symphysis fundal height, in your slide, you have written flanks not full. So when you take symphysis fundal height, we
Yes,
should not
ma'am.
write flanks not full. When you take height of uterus in weeks, there you mention like 32 weeks, flanks not full.
Yes, ma'am.
So you should not write flanks not full with symphysis
Yes, ma'am.
fundal height. Okay. One more
It
thing,
is
blood pressure
same
measurement.
slide.
Yes, ma'am.
Okay, blood pressure measurement you have written. So
Yes, ma'am.
you have measured the blood pressure in supine position. This is a stable patient. Okay. So what is the ideal recommendation? In what position you have to measure? If in a stable patient,
Ma'am,
in unstable
the ideal
patient.
recommendation, it should be in it should be in the most comfortable position for the patient, or ma'am, in a sitting position, hand resting on a
Suppose
hard
patient is
surface, ma'am,
unstable.
and
Patient is
the
unstable. Oh, you want to? Oh,
ma'am,
okay.
ma'am, semi-recumbent position, ma'am.
Okay. So that is my one more thing.
Can you
And,
go back to the palpation slide? Palpation? Yeah. In the palpation, you have not clinically done the weight measurement, which is normally accepted for a PG postgraduate
yes.
student,
Yes,
either
ma'am.
by Johnson formula or Day's formula, whichever you're using. You should have
Yes,
mentioned
ma'am. Yes, ma'am.
clinically, isn't it? That also will give you an idea about the FGR. To suspect FGR.
Oh,
Okay.
ma'am.
Either Johnson's formula or Day's formula, whichever you use.
Yes, ma'am.
How about the Johnson's formula? How do you do it?
You
Ma'am,
have
it
already
is
measured the
symphysiofundal height
symphysiofundal.
minus
Yeah.
n multiplied by 155. N would be, ma'am, if the vertex is at the level below the level of ischial spine, it will be minus 11, and at and above the level, it will be minus 12, ma'am.
Yeah.
So
And how
32
about the Day's
minus
formula? You
Day's
multiply the
formula.
symphysiofundal height by
Fundal
the
height.
abdominal circumference.
Yes,
So
ma'am.
1 gram equals 1 centimeter. That is how you get.
Okay,
So
ma'am.
clinically, either way, either by using the Johnson's, most commonly used is Johnson's, but you
Johnson's
can also
most of the
use the
time.
Day's
Just
formula.
remember one
okay.
and follow that. Huh?
Yeah, and follow that, and that will definitely give you an idea. Of course, it
okay,
is
ma'am.
not beneficial in polyhydramnias or in fibroids complicating pregnancy or in multiple pregnancy. Other than those, I think clinically you can use this for assessment of fetal weight.
So how do you take abdominal girth? Can you tell me? You have
Ma'am,
written
abdominal
girth
ma'am.
also.
Ma'am, abdominal girth, ma'am, first we'll explain the procedure, take the consent, and the patient will be on supine position, ma'am, and we'll ask the patient to empty her bladder. It is started, ma'am, beyond 32 weeks of gestation. At the lower level of the umbilicus, we'll put the ma'am inchy tape. It should be inches will be if we are measuring in inches, it should be facing downward, and then we'll
It should correspond.
it
Yes.
Okay. So madam was talking about family. You have written about family history of anomalies, है ना?
Yes, ma'am.
So I'm a fetal medicine specialist. So I was just, I know you're young. So most of the time we always ask about thalassemias, SMS, spinal muscular dystrophy is very common.
Yes, ma'am.
You are talking about aneuploidies. Most of these aneuploidies, the baby, they will not survive, and many of time diagnosis is not made. Usually the
Yes, ma'am.
history is given of children who are already there. So any collagen
Yes,
vascular disorder. So usually monogenic disorders, usually they give you your
Oh.
history. And this thalassemias and sickle cell, this is very, very important, SMA. Huh? So you should have to put some positive questions. Sometimes they don't know as such. किसी को चलने में दिक्कत तो नहीं होती है, किसी को खून तो नहीं चढ़ता है बार बार. तो you have to ask them a direct questioning for these.
Okay, ma'am.
And Rahmat and Hiba,
Just go back
in
to
your-
abdominal examination.
So one
Okay.
point
If
to
you-
Madam Jasmina. I
Yes,
am
sir.
Professor Nath. I am the coordinator.
Good afternoon, sir.
Both of them are my student.
Yes,
So
okay,
in the
sir.
same platform, they are told by the faculties, you segregate the history
Yes, sir.
trimester wise. And
Yes,
again
sir, we agree.
today,
Dr. Ashish sir had told.
yeah. And again today we are advising them club it. So I
sir,
think students
saying
get
trimester
sometimes
wise only.
confused.
Sir, it
So-
is ideal like
All
our
this
ideal
not,
teaching,
huh,
standard
do
teaching, like we
trimester
have to do
wise.
it trimester wise, sir.
Yeah, so
some
I
events
consider
happen.
I consider, so yes, because the message is going all over.
Actually,
Our
sir,
students
there is
all
some
accept-
difference in every
Uniform
examiner.
In every
That's very
textbook,
true. Huh.
we accept that first trimester, second and third
Huh.
are accepted.
Some
Please
events
also
happen.
that.
But only
Specific
thing is
with
we
the
should not
trimester.
prolong it, write only the positive things or major negative things.
Yeah,
It is acceptable
right.
trimester wise, sir.
Yes,
So
sir.
have you written history of headache, vomiting, epigastric?
Yes,
Have
yes,
written?
Yeah.
No
Yes,
history,
ma'am.
right?
Yes,
No
ma'am.
history. Okay, that's very important.
Yeah.
Can you go
But
to the
one-
next slide?
One
Next
more
slide.
point. I am so happy that all faculty are so actively involved. In one more point, I like to, because it is a case presentation.
Yes,
The
sir.
patient was hardly with us for about 4-5 days time. So we do not expect a serial ultrasound or serial assessment and
Yes,
finding
sir.
to
Yes,
tell
sir.
it is a IUFGR. So I consider at that point also they are to be explained how they will make it. Here, this is not a serial finding with which they will come to a conclusion. So probably
cannot
there is a
make-
point as well. This
They
is a
cannot
point
make a
as well.
diagnosis, Pranav sir,
Yeah.
but only
Yeah.
suspect.
They
Suspect.
can
Even
only
with a single
suspect.
finding,
That
you
is-
can
that is
suspect.
true.
Confirmation
That's why
is
they have
only by
written SGA,
ultrasound
sir.
studies.
So
Yeah,
that's
I
why
agree,
in the
sir.
provisional diagnosis they have written SGA. Now we
Yeah,
have to
yeah.
find out. We have to evaluate the case to find out whether it is SGA, FGR, or any other cause is there for small
Right.
gestation.
Rahmat and
Absolutely.
Iba, you have completed the history. Okay. What
Yes,
are all
ma'am.
the points or the risk factors which you have picked up in your particular case? Any major
Sir,
risk factor, any minor risk factor you have picked up in
Yes,
your
ma'am.
case, the
In
case
our
which you
case,
have
ma'am.
presented?
I think, ma'am, we
Yes,
have
ma'am.
already discussed. They have told, but you can just do it again.
They're only hypertension and the height of
Age
growth
they had
is less
told,
than the period of amenorrhea.
Yes,
These are the
ma'am.
only two things, right?
Yeah.
Ma'am,
Okay.
on
Go
history,
ahead. Go
ma'am, the
ahead.
patient
Go ahead.
Ma'am, I have
patient
one
had, ma'am,
question here about second pelvic grip. If you are in a busy OPD, if you are allowed to do only one grip, which grip you want to do it to get maximum information?
Ma'am, first pelvic grip, ma'am.
First pelvic grip is the poly grip. So what information you are getting in the first pelvic grip and how it is done?
Ma'am,
first pelvic grip is done, ma'am, by facing the
ma'am, we will face
patient
towards the
with
mother
first,
face, and we will stand on the right side. We will ask the patient to empty her bladder. She will, it will be, head will be, ma'am, flexed. It will be around 15 to 30 degree flexed, ma'am. We'll put our hand, ulnar border would be at the level of the, parallel to the inguinal ligament, ma'am. And then with the medial side of our palm, we'll palpate the presenting part, ma'am.
Then why you have written, if you are telling first pelvic grip is the grip where you are putting inguinal, like fingers parallel to the inguinal ligament, you have written finger converging in second pelvic grip.
Oh, ma'am,
Ma'am, in
second
second
pelvic grip
pelvic
is
grip
fingers parallel,
facing
ma'am.
towards the
It is above the, ma'am,
patient's
pubic
feet.
symphysis.
You
Actually, in
change the
this case,
direction for second pelvic grip.
not in labor. It's not very important. This is a patient who is not in labor.
It
Yes,
only
ma'am.
confirms the findings of first pelvic grip and says whether the head is engaged or not.
Yes, ma'am.
It confirms
So
the
second
finding.
pelvic, yes,
Okay.
what madam has told, second pelvic grip is the it's the important grip which gives maximum information. And in this grip, you have to write it confirms the finding of first pelvic grip and the fingers are converging. Okay, that head is non-engaged. So you have to get this information. Okay. So it is confirming the finding of first pelvic grip. What is there
Okay,
in
ma'am.
the lower port? And the head is like your fingers are converging. It is non-engaged head. Okay, understood?
Okay,
Okay,
ma'am.
ma'am.
Okay.
So how will you know that Liker is reduced? You have written Liker is adequate. So what will be your finding when Liker will be reduced?
So, ma'am, if Liker is reduced, first of all, ma'am, the period of the fundal height will be less, ma'am.
Less.
And
So
on
in this case,
palpation, ma'am, yes, ma'am. On palpation, ma'am, fetal parts will be easily palpable, ma'am. Multiple fetal parts will be
Easily palpable.
Easily palpable.
Yes, ma'am. And the head will be deeply, head also will be engaged, ma'am, in most of the cases, sir.
That why it will be
It
engaged?
depends.
It depends. You can't
Yeah, it
generalize
It
it.
depends on.
Can't
Yes,
generalize
ma'am.
it. Huh?
Okay.
Rehmat, head engaged means there is one more thing. The lower
Yes, ma'am.
segment is formed. In early
Yes, ma'am.
pregnancy, lower segment may not be formed and head may not
Yes,
be.
ma'am. In that case, ma'am, there will the head will not be engaged. Only the fetal parts
So
will be easily palpable, and the period of gestation
aside.
will be
Yes.
lesser as compared to her period of gestation, ma'am.
Yes. Now, one more thing I want to say is that did you mention whether you repeated the blood pressure? First reading was 150/90. I don't think you mentioned repetition of BP reading.
Ma'am, we
Normally,
have not mentioned the management part, ma'am. So on admission, BP was 150 by 90 millimeter of mercury.
Acha. Okay.
Ma'am,
So what do
actually,
you
ma'am, we
think?
have written the second reading. Ma'am, we have to take. Ma'am, we have taken first reading. It was raised, then we make the patient rest, and then we have taken we have taken reading again, and then
And
we
then
have
it was
written the
confirmed.
150 by 90, ma'am. It was raised in both the readings, ma'am.
So which antihypertensive she must have been on? You have written she was on antihypertensive drug. So what would have been that drug? Any idea?
Ma'am, most commonly, ma'am, tablet labetalol, ma'am. Tablet labetalol.
Okay. So what is the usually ideal blood pressure do you want during pregnancy? During the antenatal?
Ma'am, it is less
Her
than
BP was
140 by 90
150/90,
millimeter
no?
of
So
mercury, ma'am.
what ideal we want to keep it during pregnancy?
Ideally, it should be, ma'am, less than 140 by 90 millimeter mercury. It
Yeah.
should not
So
be
and
equal to
during antenatal
140
period,
or
140 by 90, and post after delivery, 120/80 is good enough. Because
Yes.
there's a placental circulation during antenatal, we don't want the BP to go down much.
Yes,
So
ma'am.
how will you investigate?
Basic
we do all the-
investigations you have done in your case?
So, ma'am, after admitting the patient, first for maternal assessment, we have sent routine investigation, ma'am, And along with that, we have send the ultrasonography. Ma'am, complete blood count, random blood sugar, KFT, LFT, ma'am, urine RE, serum calcium, LDH, that were sent, ma'am. Along with that, ma'am,
additional investigation.
Serum calcium. She's
virology were also sent.
Hypertensive disorder in pregnancy. So KFT, LFT, so you have to send hemogram, KFT, LFT.
Yes, ma'am. KFT, LFT, you have sent, ma'am.
Okay.
And
for additional investigations. It's not specific for your case, but can we order for additional investigation in which cases, if so? We do order for infection profile, isn't it?
Yes,
when you suspect infections like toxoplasma, early onset
yes,
FGR.
search profile, ma'am.
Yeah. No, for
toxoplasmosis,
for syphilis.
This is not early onset FGR. This is a late onset.
It is a late onset.
Yes,
so
for late onset, you also can do
there's
it.
no point of doing amniocentesis or any viral testing. Okay,
Yeah.
until this patient doesn't have any history-wise,
too late.
He doesn't have or viral markers positive.
Yes,
so you say before 24
onset.
you think, huh? So in this case, no need.
No need.
And for fetal assessment, ma'am, we have done ultrasonography with Doppler study, ma'am. So
any
in
genetic
ultrasonography,
testing, can it be indicated for late onset?
No, ma'am. It is usually indicated in early onset FGR, ma'am.
And if early onset, which genetic test you will do?
What
early
are the
onset?
indications? Where
not associated with which test you will do. If you find early onset FGR before 24, 26 weeks.
Ma'am, in early onset FGR, ma'am, we do, ma'am, amniocentesis can be done if there is
and then which test? Either you have to do
Microarray.
CMA, chromosomal microarray.
Yes, sir.
CMA is the ideal test where you see deletion and duplication.
Yes,
so
ma'am.
you will do in very early onset FGR. So in this case, can you tell me what Doppler studies will you do, and in ultrasound what all you? So what you will look in ultrasound and what you will look in Doppler?
Ma'am, in ultrasound,
like
we will see,
biochemical markers also.
Yes, ma'am.
Like PAPE, which is less than.
Yes, ma'am. Plasma associated
0.4
pregnancy
and inhibin and alpha fetoprotein. They are biochemical markers which indicate FGR.
Yes, ma'am.
All these are for early onset. Okay, so
for
your
first
case is late
trimester.
onset FGR. So you can proceed. What evaluation you will be doing for your case?
Yes,
late
ma'am.
onset FGR. What madam has asked, like
Yes, ma'am. We will see the
I
biometry.
just want to add, if you have the option in the first trimester, we are doing your first trimester combined screening. Okay, so in which we are doing an anti and age, and we look at the dual your PAPE and your beta SCG. Okay, so PAPE gives us an idea. If it's less than 0.4 mom, then there is a chance that the baby may have FGR. So that you do in the first trimester. That is between the window of 11 to 13 plus 6.
Yes,
yes, ma'am.
Okay. So now, can you tell me what all you will see on ultrasound and what you will, which vessels you will do the Doppler for confirming your diagnosis?
Ma'am, here we will see fetal biometry, ma'am, to calculate the estimated fetal weight.
Madam asked the Doppler.
In Doppler
first trimester,
study, we will see middle cerebral artery. Middle cerebral artery and umbilical artery.
First ultrasound बताओ फिर Doppler. Ultrasound में क्या देखो? Biometry में क्या
देखो? Ultrasound में we will see Lycor, ma'am, Lycor volume, placental location, and placental grading, and fetal estimated fetal weight, ma'am.
What about AC, BPD, HC? You will have to do everything to calculate the estimated fetal weight. So you will look at BPD, HC, female length, AC, okay, abdominal circumference, and then automatically it will give you the estimated fetal weight of the baby. And you have to put it in plot it. You have to put it and see which centile they are falling. Okay, especially we have to look at AC and estimated fetal weight.
Yes,
whether they are below 10th centile or they are above 10th centile. Okay, ultrasound, you do of which vessels now? She's 36 weeks, 2 days.
In late onset FGR, ma'am, middle cerebral artery is usually first affected. Ma'am, we see umbilical artery, we see middle cerebral artery, ma'am, and then we can see
MC itself alone has no meaning. You have to do it with umbilical artery. Umbilical artery.
Yes, ma'am.
And what is CPR?
Also,
what is CPR? Cerebral perfusion ratio. What is CPR?
Ma'am, cerebral percentile ratio is the middle cerebral artery pulsatility index divided by umbilical artery pulsatility index.
Very good. And we will look at CPR. And you will also do any role of ductus in late onset FGR? Ductus venosus?
Ma'am, ductus venosus is, ma'am, there is has more role in the early onset FGR, ma'am, than late onset FGR.
So late onset FGR, there is no role of ductus venosus. What about uterine artery? Uterine artery Doppler?
Ma'am, uterine artery Doppler has more role in early onset FGR, ma'am.
You can do. Some studies say,
Yes,
but
ma'am,
ductus has no role unless and until there's absent or reversal flow in the umbilical. Otherwise, there is no role, and rarely you see that in case of late onset FGR.
Yes, ma'am.
Okay.
I would just like to add, madam, if not for this case, first trimester, when you do the NT scan, you can also combine it with uterine artery Doppler.
Yeah. Yes,
where
ma'am.
PI is more than 95 centile. If such cases you reassess and find out also, as I said, minor or major risk factors. If more than 3 minor or 1 major risk factor, you reassess at 20 weeks. And then if at 20 weeks uterine artery Doppler is normal, then you can assess fetal size and umbilical artery Doppler only in the 3rd trimester. If that is abnormal, then serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks.
Yes, ma'am.
This is
so most
what
of the
routine.
guideline says you do a uterine artery between 18 to 24 weeks. If it's less than 95th centile, your uterine artery, you have to take the mean of right and left.
Mean of both, and also you see for bilateral notching at 20 to 24 weeks.
And then you can
that also gives you an idea.
If it's normal, if it's abnormal, then you scan at 28 weeks.
28 weeks. You start fetal biometry and umbilical artery Doppler.
Yeah,
that is the guideline.
Can you go to provisional diagnosis? Provisional. Okay.
Yes,
now from here, you have told it's a SGA. Okay. How are you going to differentiate SGA from FGR?
Ma'am, to differentiate SGA from SGR, ma'am, FGR, ma'am, first of all, ma'am, we will see the serial ultrasound, ma'am. So in serial ultrasound,
now there is no time for us.
At 36 weeks and 3 days, what
36 weeks, 3 days. Yeah.
Yes, ma'am. If only in one sitting, ma'am, I will see, ma'am, Doppler study. If there is Doppler changes, ma'am, and along with that, if the estimated fetal weight is less than 10 centile with the Doppler changes, we'll confirm it as a fetal growth restriction. If there is no Doppler changes, ma'am, there will be, it is small for gestation, ma'am.
If the estimated fetal weight is less than 3 centile?
So, beta, there is a Delphi consensus.
Less than 3 centile,
yes.
There's a Delphi consensus. Can you tell me for the early onset is less than 32 weeks and late onset is after 32. So most are
so just ma'am 1 minute.
What is the Delphi consensus for diagnosis of late onset FGR? Can you define?
According to
late onset
as Delphi consensus 2016, ma'am, we have, for late onset it is the more than 32 weeks with the absence of any congenital anomaly and estimated fetal weight or abdominal circumference is less than 3rd centile, or ma'am it
so if it's 3rd centile, third centile you can directly label as
if it is 10,
if it's less than 10 centile, क्या associated होना चाहिए?
Then we need Doppler changes, ma'am. For that, we need
2 out of 3
MCA or CPR, ma'am.
CPR or क्या?
Yes, ma'am. And there will be a 4
umbilical artery PI more than 95.
Umbilical artery Doppler and the middle cerebral artery PI. Ma'am, there is a growth. Ma'am, there is a fall in the growth chart. More than 2 quartiles.
50th centile. पहले 80th centile, now it has come to 30th centile. So there is fall of more than 50 centiles. That is 2 quartiles.
Yes, ma'am.
Also, that is the importance of doing the growth velocity. That's why we are to see how it is behaving, because sometimes your late onset FGR may be more than 10 centile and then also their growth is restricted. So it's very important to do CPR and also to chart so that you see the growth velocity. And you have to look at CPR and your umbilical to make a diagnosis.
And all FGR fetuses may not show evidence of a fetal compromise, like abnormal Doppler or even reduced Likert. Not always.
Yes, ma'am.
And usually it is not associated with your preeclampsia, but in your case it is.
Yeah,
usually it is.
Yes, ma'am.
Preeclampsia is associated with your early onset, but this is a case of gestational hypertension. Actually, preeclampsia causes more FGR rather than your gestational hypertension itself.
Yes, ma'am.
Okay. So now you have made a diagnosis that you have any findings of this patient?
Yes, ma'am.
Yes, ma'am.
So can show the findings. Because we have discussed how will you manage. So can you tell me?
For our case, ma'am.
Hiba, if you have so many ultrasound, you just show me the slide. So which ultrasound you will use for your dating? So most important for FGR is your dating. So how will you date your pregnancy? There are so many ultrasounds.
Here we have 7 weeks ultrasonography, ma'am. 13. Ma'am, we have 7 weeks ultrasonography, so that will be more accurate for dating, ma'am.
Yes, your first trimester earliest where the CRL. If there is a MST ultrasound, you will not take it for dating. But if you have a CRL showing CRL, then you will take it for your dating, and it is plus minus 5 days if it's done for 9 weeks. Okay.
Between
This is very, very reliable, and you will change your date only your EDD only if there is discrepancy more than 5 days.
5 days.
5 days. If it's same, if
And
within
between
5
9
days,
and
you will
13
not
also, between 9 and 13, discrepancy if it's more than 7 days.
7 days. So it's very, very important. So most important thing for your FGR or any high-risk pregnancy is your dating. And once you have dated the pregnancy, you're not going to change. What ultrasound people are, they're changing EDD every time a patient, madam, ab to mera ye. So they have to put the same EDD when they are plotting.
Yes,
So this is a very well worked up. So you will date her according to 7 weeks. So dates are correct. Because if you don't have the correct dating, it's very difficult to say it's FGR or it's wrong dates. Or it's preterm rather than being FGR.
Even if the patient comes late in second trimester, you can depend on
Dr.
this.
Hiba, like
EPD.
as madam has started with this dating here, just I want to ask, like, do you know what is excellent date, good dates, poor dates based on history and your ultrasound finding?
What is the importance ki dates are correct? You said, how do you take in history the dates will be correct?
Ma'am, as per the first we have to see the menstrual history of the patient, ma'am. If the menstrual history of the patient is regular.
Connect your laptop.
I think it's running. I thought my laptop is going. Just check. Battery is low. Yours, I think is.
Yes, ma'am. मैं वो power bank लाती हूँ. Yes, ma'am. For dating, ma'am, I was saying, ma'am, we will check the menstrual history of the patient, ma'am. If the menstrual history of the patient is regular, which she has regular cycles and 28-day cycles.
At least 3 cycles, है ना? 3 regular cycles.
At least 3 cycles, ma'am. At least 3 cycles we take, ma'am. If it is regular, then we rely more to the menstrual cycle, ma'am. Or then we rely on the our USG finding. And if it is first trimester
actually,
USG,
Hiba, you have to rely on ultrasound. For majority of our patients, they don't have an early ultrasound.
Yes, this is incorrect.
Yes, ma'am. If it is first trimester USG, then they rely on USG.
We are lucky that this patient has a first trimester. Majority of our patients, they have no ultrasound also sometimes.
Yes, ma'am.
So if a patient comes in third trimester, how will you date her? And she has no previous ultrasound and she's not sure of her date. She has conceived in lactational amenorrhea. How will you date her? If it's very common in our government hospital. They are coming at third trimester. Then what will you do?
Ma'am, we can, based on some history, like, ma'am, history of quickening, ma'am, and from history of any fruitful intercourse, ma'am, and
What?
No.
Fruitful
history
intercourse.
of quickening, date of history of quickening.
Don't say that.
But this is not that much reliable, but that can be also taken, ma'am. And from
so
examination,
what you can do is, you can, in third trimester, it's not a dating ultrasound. It is a basically growth ultrasound, and you can do 2 ultrasounds. Now and 2 weeks later. And if both of them are corresponding, then you can use based on a single ultrasound, you can't date. You have to do 2 scans.
And
2
most
weeks
important,
apart.
FL in the third trimester for you to
and
calculate.
FL is, and we have this transcerebellar TCD. This is also can be used because that's a very common pair.
Transcerebellar can be used from 18 to 40 weeks at any time.
So it is also very reliable. Okay. Your transcerebellar diameter or your 2 scans done 2 weeks apart will help you to date, because it's very difficult to know whether it's a preterm or it's a FGR baby. Okay. So looking at this, can you elaborate, any one of you, your scan findings?
Ma'am, in 34 weeks ultrasonography, the abdominal circumference was, ma'am, less. It was 31 weeks, and her estimated fetal weight was 1.7 kg. At that time only, it was FGR, ma'am. It was less than 30%.
So, beta, every AC, you should have your centiles both for AC and estimated. It's very, very important. Okay, because female length and PPD is not affected by HC. Is not
only the AC.
AC and your AC is affected.
in FGR?
Ma'am, in case of FGR, the subcutaneous fat, due to poor nutrition, the subcutaneous fat of the abdomen is all the not only subcutaneous fat of the abdomen
Liver is
earlier
affected.
affected, ma'am, and also there is reduce in the glycogen storage, overall leading to reduce in the abdominal circumference, ma'am.
So most are definition, they take it at AC and your estimated fetal weight. So that you're showing is less than third centile. So if it's less than third centile, what do you infer, Rahmat?
Ma'am,
Your 34 weeks?
we'll inform the patient. Ma'am, we will ask the patient for serial fetal growth assessment and also.
So it is a FGR.
And ma'am, fetal well-being.
FGR, yes.
Why we are working so hard to differentiate SGA from FGR? Why we are working so hard? Why?
Ma'am, because in case of SGA, ma'am, the outcome of the fetus is not affected, ma'am. But in case of FGR, the long-term outcome and neonatal outcome is affected, ma'am.
So it may lead to stillbirth. So morbidity and mortality is more in case of a fetal because it is a pathological, and that is constitutional SGA. So when will you deliver SGA babies? What are the guidelines says regarding SGA babies?
Ma'am,
when will you deliver your SGA
30
babies?
to 39 we suggest.
So you don't let them go till 40 because earlier it was thought it can be taken 40, 41. You should deliver them by around 39 weeks and you have to follow them two weekly because SGA may also change into FGR later. So you have to follow them 2 weekly. Your SGA and deliver at 39. FGR baby once you have labeled.
How frequent you will monitor in SGA and what are the monitoring parameters?
Monitoring, So you have to do what guideline, patao.
Ma'am, for monitoring of SGA baby, we'll follow up by ultrasonography, ma'am. We'll ask them
Don't
to.
Don't say ultrasound. Always ultrasound with Doppler. Ultrasound with Doppler.
And
for
with
FGR,
Doppler,
SGA, everything is Doppler.
Yes, ma'am.
And there also you have to have the charts. You'll have to serially measure it.
You have to point out.
You have to have the
biometry
and growth charts.
So growth
charts available for you.
And what are the monitoring
Which
parameters?
Ma'am, in cases of FGR, ma'am, in cases of FGR, ma'am, our monitoring depends on the stage of the FGR, ma'am. If it is like early placental insufficiency, there is changes only in the uterine artery, umbilical artery, or ma'am, then we will do, ma'am, weekly we'll do the Doppler, and we'll 2 weekly we'll estimate the fetal weight, ma'am, biometry, and we'll do CTG also weekly, ma'am, and we will deliver the patient at 37 weeks. But in stages in severe insufficiency,
actually, your stages are more for your early onset. Your staging is more
early onset.
Yes, staging only limited to early onset FGR.
Early onset, ma'am. Yes,
late onset FGR, no. The staging does not
Yes, ma'am. In late onset FGR,
they have gone.
I think we should now come to the management of the case because there is one more session after this.
So how much time do we have?
I think we have already passed our time.
Okay.
Okay.
I think we should go to the discussion of management.
We'll sum up the management done in
you
this
can
particular case.
In another 5 to 7 minutes.
Okay, sir.
We can take 5 to 7 minutes. Where the kids have gone, I don't know. They disconnected.
I think her charge must have totally exhausted.
Even I got confused.
I tried, I said, this shows 72%. Why is it showing no, your battery is low? Where are they?
I don't know why they were not sitting. My laptop is connected to the charge. They were not sitting with the cord.
They must have had, these residents have too many things to do. Their calls and their emergencies and.
Dr. Jasmine, you are from where?
I'm from All India Institute of AIMS, madam, from Bhubaneswar.
Bhubaneswar. Okay. You're from Bhubaneswar. And Dr. Rupkala, you are from?
From Bangalore, madam. Rajarajeshwari, Bangalore.
Bangalore, okay. Yeah. They told me, I just missed her.
Ma'am, sorry, ma'am. We had some network issue and problems, ma'am. So we are back.
Achha, ab ye batao, how will you manage this case, bas? Just last part. How will you manage this case? Now she's 36 weeks, 3 days with late onset FGR. Your CPR, I think we will have.
How frequently do you do NST and how frequently will you do Doppler
how
and
will you
biometry?
monitor?
That's a question.
Come with decreased fetal movement, hai na?
Ma'am,
Yes,
in cases of normally in late onset, ma'am, in our case,
No, in your case.
In your
Talk
case,
about
now
your
now
case.
come to your case,
Okay.
management.
In our case, ma'am, she is at 36 weeks, 3 days. She had changes in the estimated fetal was less than third centile and changes in cerebroplacental ratio. So, ma'am, as per the guideline, USG obstetric gynecology guideline, we decided to terminate the pregnancy because the estimated fetal weight is less than third centile, ma'am. So
But
for
didn't
that,
you
but
do the
CTG
Doppler and
was,
biophysical profile?
yes, ma'am.
yes, ma'am, that
Yes,
was
ma'am.
done, ma'am.
That was done, ma'am.
That was
Doppler showed,
normal.
ma'am,
So that you have to do. Why you have to do? Can you tell me?
Role of biophysical profile?
Biophysical and your CTG in
NST.
your case.
Ma'am, we have done CTG, ma'am. We have done CTG and it was reassuring, ma'am.
Ma'am, we have to do to know the,
Yes,
ma'am,
ma'am.
fetal compromise, ma'am. Whether the fetal, ma'am, we have to terminate it by mode of action, ma'am. We have to terminate it urgently by cesarean section, or we can give.
What do you mean by compromise?
Ma'am, compromise, ma'am, if there is severe changes, like, ma'am, there is
Absent and
absent and isolated flow. Yes, ma'am.
Or in case of late FGR, in case of early FGR, if there is changes in the ductus spinosus, like
that is Doppler, na? Abhi aapne CTG bola.
Yes, ma'am. Doppler.
Yes, ma'am.
So, message I want to give is that you should not deliver because your CPR is less than fifth centile.
Yes.
That should
Yes,
not
ma'am.
be your trigger for a preterm delivery. Okay.
Yes, ma'am.
Have to deliver them at 37 completed, but you will deliver them early. Your trigger will be your CTG. So any abnormalities in your now everyone is talking about computerized CTG. So any decrease in your short-term variation, or there is your biophysical score is less than 4. So these are two indications which you will deliver preterm. Otherwise, you will go till term. So in your case, if your CTG is normal, you can go for induction. In late onset, if there is no, you can go for induction. So what can you tell me about how you proceeded in your case?
And what is normal CTG?
Ma'am,
in normal CTG, there will be variability of fetal heart rate between the first of all, the fetal heart rate will be between 110 to 160 beats per minute, and the variability will be within 15 to 20 beats per minute, ma'am. And there will be acceleration, ma'am, and there absence of deceleration, ma'am.
Very good. Okay.
How about BPP in your case? Was it also normal?
Yes, ma'am. In our case, it was normal, ma'am.
It was
so what is normal BPP? What is the value?
So what is the importance of BPP in FGR? Late onset, like in your case.
If ma'am biophysical profile is less than equal to 4, it suggests urgent delivery. If it is less than equal to 6, ma'am, it is mildly affected, and if it is more than equal to 6, ma'am, we can the baby is less affected, and we can go for induction.
Just tell me what 5 parameters you see in your BPP. Just tell me the
parameters. In biophysical profile, ma'am, we see the gross fetal movement, ma'am, breathing movement. And then the movements of limb and amniotic fluid index and
NST,
ma'am.
Like
and tone. Most important is tone. And you give a score of 2 and 0. Okay.
Yes, ma'am.
So so in your case, what did you do? What was the outcome?
Ma'am, it was 8 by 10, ma'am.
What is modified biophysical profile?
So which parameter was gone? Liker.
Liker, ma'am. It was reduced, ma'am.
What is SDP and what is AFI? Just last question. What is SDP? Single deepest pocket, and what is AFI? Amniotic fluid index.
And when do you do what?
Ma'am,
which is better in case of alive?
Here we prefer, ma'am, SDP, ma'am, and SDP is the only single deepest pocket that is found.
So what is adequate? What is adequate SDP? When you will say it's adequate? Liker is adequate?
Measurement.
It is 2 to 8 centimeter, between 2 to 8 centimeter, ma'am. And if AFI is between 5 to 20.
Where is that 8 figure?
More than 2 centimeters is okay. 2 to 8 ka zarurat nahi hai. If it's more than 2, it's okay. If it's more than 8, it is poly.
Yes, ma'am.
Okay. So and AFI, how do you do AFI?
Ma'am, for measurement of AFI, then we divide during ultrasonography, we divide the patient's abdomen into 4 quadrants, and we measure the largest pocket from every
pocket where there is no cord on fetal part, and then you add. And what is normal AFI range? There you have a range.
It is more than 5 centimeter, ma'am.
So more than 5, it is no, and poly more than
25, ma'am.
Okay.
How do you decide to deliver the patient now? because we have 3 minutes.
Ma'am, in our case, the patient was complaining of reduced fetal movement, but the CTG was reactive and it was 36 weeks, 3 days. So we terminate.
What is the
We
Bishop
gave
score?
induction.
Don't
What
say
is the Bishop
that.
score in your case?
Whenever you talk of induction, you have to tell the Bishop score.
Bishop score.
Yes, ma'am. The Bishop score was, ma'am,
Yeah.
7.
Seven.
Yes,
It was
Depending on
7.
that, you decide.
Yes,
It
ma'am.
was 7.
It was 7. So we gave only 1 dose of prostaglandin gel, ma'am. But after giving 2 hours, there was some
7 में तो
CTG.
जरूरत ही नहीं था, वो तो favorable हो गया तुम्हारा.
Just ARM and syntesolon is sufficient.
हाँ, there is no need to put Servigen. Below
You are
6
going
you
to
have.
overstimulate the patient and then cause distress. Iatrogenic.
Okay, so you can.
Yeah, no problem.
हाँ, ठीक है. I think
Hello,
very
madam.
good. I'm very
Hello,
impressed.
hello, ma'am. Hello, ma'am.
Yeah.
Hello.
Yeah,
Ma'am, am I audible?
Yes,
Ma'am,
audible, sir.
ma'am, this is Dr. Fuzal Ahmed, ma'am. Actually, both of them, they are our students. I'm working as an assistant professor here. And recently, they are going to appear the final exam. The one thing I have a confusion after going to all your your enthusiastic participation. First of all, I'd like to say thank you so much, madam. And really, your knowledge and everything they have.
Students are brilliant.
They have done a very good job.
I'm impressed, yeah.
Ma'am, one thing
You have
actually,
withstood all the pressure.
ma'am, by next 6-7 months, probably they will be appearing their exam.
Yeah.
And
So
what
do
will be
very
your,
well.
ma'am, what will be the suggestion? Because until today, we're discussing with them that you present the history according to different semester, like semester 1 or semester 3. Now again, they have clubbed together. So what will be your suggestion, madam, for them? I have to advise them for the next coming exam for them, actually.
Actually, in Safdarjung Hospital, we are doing trimester-wise history.
Madam,
Yeah,
all
yeah,
textbooks
also
also mention the
trimester-wise.
same, madam.
So
We
All
also follow
standard
same.
textbooks mention the same.
Always
So it's
better.
acceptable. There's nothing wrong in trimester-wise history.
Sir,
This
this is postgraduate examination, so it really doesn't matter as long as the most important factor when an insult has occurred to the patient or the baby, that is the most important. So here they had probably, I don't know whether this was a real case or a created case, but
no, ma'am, this was a real case. Madam, one more.
Excellent,
Ma'am,
excellent.
one more.
1 minute, let me just complain, sir.
Yeah.
Let me just complete. So in that case, when we are making presentation, things are different. And when we are presenting orally, things are different. So this is presentation. So they have had to arrange so many sentences and all that. Otherwise, I don't think there is much of a problem they will ever encounter. They have done very well.
Okay, ma'am. Thank you so much.
Good job,
One more point, madam. Actually,
Yeah.
this patient, she was under follow-up of a private doctor. And Padmaja, madam, you point out one important point that after having a sonography done at 32 weeks, and she was informed by the private doctor that whether her baby growth is lagging. And at that time, I remember because this patient came to us and here in SMC, the tertiary health center, and during that phase of time, the period of gestation, the private doctor was following the patient with the weekly CTG. So he had some problem with the CTG, I don't know. But the following sonography at 36 weeks, it was also done by him. And then he could record that there is some discrepancy in the growth. Then only the patient was referred to our hospital.
So actually, it was a missed opportunity, something.
Maybe, yeah. So basically, madam, the patient came to our institution to have a safe delivery. She was already with the opinion that her baby was lagging behind.
So it's okay, sir, to write that.
I think you have taken good care of her.
Yeah.
And it was a happy ending.
Thank you so much.
Because late onset FGR is difficult to diagnose. That is the problem with late onset. Early onset, because of the discrepancy, we diagnose it earlier. So that is the problem. Diagnosis is late. That's why we lose our babies and it leads to late stillbirths.
Yes, sir.
Nene, thank you so much, madam, all expert faculties for giving your positive feedback and guiding our students. Thank you so much. Really, they learned a lot, madam. Thank you.
Thank you, sir.
Thank you, sir. Your student also appeared very nicely.
Thank you, sir.
Bye-bye.
Thank you so much, ma'am. Thank you so much, sir.
Thank you, Hibba and Ramat. Done well. Thank you.
Fast.
Yeah.
Fast.
Thank you. So all the faculties, I think if it is you have done, I think we can conclude this session. Thank you so much. Dr. Padmaja Madam, Dr. Upma, and Dr. Jasmina, Dr. Rupakala Madam. I am sure all the faculties have really done well, and I would like to have a quick comments from each examiners for the students, no? Because they are going to appear in the exams. Yes, ma'am.
So I think
The
Dr.
first barrier,
They have done
Padmanaja ma'am,
yeah, they have done very well. They should be talking as consultants rather than as students in the exams, because they are that is MS exam. So that is one important thing. And that initial whatever discussion took place, let them pay attention to that, somewhere months and somewhere weeks and all that. So these are small things, which make a difference between a student and the consultant. I think that is
Dr. Upma, any quick points for their betterment and for their on their performance?
I think I always tell my students that history should be in patient's language, and you should not use the technical medical terms for the history. And the FGR is a little difficult topic, and I think they need, but they did quite well. I was very happy with their understanding of the subject.
Yeah, if you made a point, madam, on history. So I'd like to again re-emphasize that there was discussion on the first trimester, second and third trimester. What I'd like to emphasize is that in exams, hardly the examiner is going to listen all the history, what is written. They're actually not, they are not.
That's very true. You don't have. But they should write trimester wise.
I always tell the students they should have a good summary prepared, and they should not go read and everything, because no examiner is there is no time to listen everything from the patient's particular till to all the examination. So they should prepare a good summary after taking all the information, and that should be the point. That is, rather than concentrating only on the trimester, yes, they can take it. If the examiner checks their case sheet, that should be documented in a trimester wise. Then the examiner will feel it is a systematic way.
Yes, if just let me add a point here. This one thing, if you are mentioning all the complaints according to different semester, then there is always a less chance that we will miss out the important points. So it's better always to write.
But most of the time we don't listen to that, but it should be written in that way. And in beginning only, I think that the opening statement should tell all about the patient. So the examiner should understand what they are going to, basically where to ask.
Yes.
So what is the POG, what is LMP, so obstetric history formula. So in the beginning only, they should give an outline of the case.
I think the presentation matters quite a bit. The similar history can be different way presented by another student, and this course in their the way of presenting and the way of arranging the sentences. All this matters very much. So next, Dr. Jasmina.
I mean, doing writing in trimester wise is nothing wrong, because standard textbook.
Nothing wrong.
But the summary should carry all the history examination points positive. Then go to the provisional diagnosis. That is enough.
Was the thing we want. That was the thing I wanted to point out. That is how you present.
Is acceptable.
So make a summary and do an excellent presentation. So whatever, whether you
should include all the positive points, then go for the provisional diagnosis.
Negative point. Dr. Jasmina, anything
like what I observed, like they have done very good job. Like they have presented the history, even the flow of answering the questions, very nice. Like one tip for final exam, like any question asked, think before answering. Okay. So if you are sure of answer, then go with the answer. If you do not know the answer, just you tell the examiner you don't know, so that next question will come. Don't waste the time of examiner.
Yes,
thank you, madam.
And also all the answers should be stuck to be for our patient, whichever they are presenting, not in general. The treatment or the investigation should be specific to the case presented.
And they should say, how I will manage my patient. I will
that
do
is
this,
what it is important.
So,
thank you so much, madam. Yeah, I think for both the students, Dr. Hiba and Rahmat, they once they cross the bar, the moment or the day they said, sir, yes, we are ready to present in the case in the national platform. I think that's a great applause. Once they are ready to present any examiner in front of all of the students, that needs a very much applause for them. And I'd like to very much sincerely thank both the students, Dr. Hiba and Rahmat, and I wish them all the best. And at the same time, I'd like to have a thank you and express my sincere regards to their HOD, Dr. Pranay Nath sir, for guiding them, for allowing them the presentation, as well as Dr. Fuzail Ahmed, who has been very instrumental in preparing them to the students for this platform. So thank you, the team of Silchar Medical College, for your excellent presentation, as well as all the faculties for doing justice to the topic, as well as for bringing such a great discussion in this case discussion. Thank you so much.
Thank
So
you
now,
very
without
much.
wasting any time, yes, without wasting any time, so we'll move to our next another important session that students are always actually many times confused once they are given a specimen, how they are going to approach it and what they are going to start, and the initial starting time is always their confused, and many times they are very fearful on this. So we have started from this year on the case on a specimen. So last time, Dr. Arup Kumar Mazi had different types of fibroid and how to approach them. Now today we have Dr. Anupama Dave. So Dr. Anupama Dave, Madam is professor at MGM Medical College, Indore. So Madam is going to take a few specimens for today and how to approach them. What are the typical maybe questions asked and how the student should answer. So I'd like to request Dr. Anupama Dave, Madam. Ma'am, over to you. Please share your screen and you can
a very good afternoon to all of you. At the outset, I would like to thank Dr. Sheila Mane ma'am and Hafizur and the team for giving me this opportunity to join in this ICOG class. Is it visible?
Yes, ma'am, you are visible. You can, if you have a screen, you can share.
My slides.
You have a slide?
Share. Yes, I have slide. Just a minute.
You just can share it.
Yes. So I think now they are visible.
No. You just can make it slideshow. You can make it slideshow. Yeah, perfect. Please go ahead, ma'am.
So the basic theme on which I'm going to give this talk is orientation to gynecological specimens. So I would like to begin with this quote. The person who gets the farthest is generally the one willing to do and dare. The sure thing that the boat never gets far from shore. So whenever a specimen is given or whenever a student is asked something, they try to remember the things, like they try to remember the uncommon things and they try to speak it. But that is not right. And this is what the boat never gets far away from shore. The examiners always want things which are clinical and which are relevant to that particular case or to that particular section on which they're asked. Now, as an introduction, why specimens are asked in exams? Well, specimens are asked because they have some clinical context in it. You get a specimen of a uterus and tubes and ovaries removed, and then the viva lands up in steps of hysterectomy. So this is how, with specimens, we begin with actually testing the student's knowledge. Then the next aspect is how to begin the description. Well, we all might have seen that initially students, just like they in their surgical exams, they mention that it is a soft tissue specimen. It seems to be it is tubular or it is rounded, oval, and it seems to be the uterus. But this is something wrong. We know it's an obs gynae viva and we know it is a gynae specimen. So it is better to go to the point. Like, this is a specimen of the uterus and then start describing it. Then following that, once they've made a diagnosis, there are many questions which the examiner wants to ask in order to test the student's knowledge. So subsequently, the commonly asked questions I would describe. Now, as far as gynecological specimens are concerned, this is a list of things which are usually kept in exams. Uterus with anomalies, uterus with tumors, adenomyosis, uterus with molar tissue, some ovarian pathology, sometimes a vulval carcinoma specimen, that whole of the vulva has been shown, or a tube with ectopic or adnexal links. When describing any specimen, students must follow the standard order. first identify the organ seen, whether it is the uterus along with tubes, ovaries, or only the fallopian tube. Following identification, the external appearance, the size. The size of the uterus is usually mentioned in terms of size of pregnancy, that is 10-week size uterus. Instead of a 10 to 12 centimeters uterus, we usually mention 10-week size, 12-week size, etc. Then the shape, it is uniformly distended or irregular shape it has. And then the color. You might have seen that in many specimens in which there is torsion or hemorrhage, they look like bluish or blackish. So all this has to be mentioned. And then the cut section, like it has a whole organ is not kept as such. It is cut in order to show or identify the point which they want to mention, like uterus is cut open to show the fibroid or a polyp. The walls are shown with adenomyosis, etc. So these are the 3 points: identification, external appearance, and cut section. Now, because fibroids have already been covered and much of that part has been covered in the previous class, I've been asked to tell mainly about ovarian tumors, and some more specimens I would explain, which I felt were important. So ovarian tumors, you get a mass in that jar, you see, and you can easily identify that it is the ovary. The ovary could be of normal size, or it could be extremely enlarged, or it could be mildly enlarged. So, and depending on whether it is only the wall is seen because internal fluid has been removed, or whether it is fibrous tissue is seen, you can describe it as an ovarian cystic lesion or an ovarian fibrotic lesion, or a thick-walled ovarian tissue in this manner. So first identify the specimen, then describe the gross part, the size, the surface, the cut section. Then the contents. The contents actually have been removed, but depending on what you are thinking, you can describe, like it could be a serous cyst or a mucinous cyst. If it has hairs seen, it could be a dermoid, or it could be a solid ovarian cyst, solid and cystic. So in this way, the gross is described. After that, you need to give the diagnosis and then classify it, whether it's an epithelial or germ cell or stromal tumor. Following which, the examiner would usually ask some clinical features associated with this size of ovarian tumor or mass, and sometimes they would ask the complications. So like, as you can see in this first picture, a small ovary is seen. So it seems to be a benign ovarian mass. It could be follicular depending on the size. The size is too small. It is nearly 4 centimeters, 5 centimeters. So it could be a follicular cyst, corpus luteum cyst, theca lutein cyst. You can see special crystals if it is a theca lutein cyst. It could be a simple serous cyst, or even a para-ovarian cyst, because in a para-ovarian cyst, we usually remove the cyst and it is seen as a structure like this. Sometimes if it is only the wall and the wall is bluish, it could be an endometriotic cyst also. Or chocolate colored. Chocolate color does not remain, but bluish, blackish hue remains, and then it could be labeled as an endometrial. So this is a small ovarian cyst. Now you can see in this picture, the uterus, cervix, along with one-sided ovary and an ovarian mass. So you can clearly see that this is a normal ovarian tissue and this is the ovarian mass. So in this specimen, you would describe that this is a specimen showing the uterus cervix with an one-sided ovarian mass in which ovaries have been removed. So unilateral salpingo-oophorectomy. Hysterectomy with unilateral salpingo-oophorectomy. This is what would be described. If, as you can see in this picture also, on throwing light, it is translucent. So it could be a serous cyst, it could be a mucinous cyst, which has been removed in toto. If it is a serous cyst adenoma, usually this dimension is a bit bigger. They could be bilateral, so you could have 2 cysts in that jar. It is a unilocular cyst. Only few locules are present. There's a thin wall and clear fluid.
Then the commonest question is whether it is benign or malignant. Commonly, it is a benign epithelial tumor, but then again, it could have borderline malignancy if it is there for a longer time. Then the viva shifts over to borderline ovarian tumors. So as I had mentioned, it could be bilateral as well. So simple epithelial ovarian mass is a serous cystadenoma. Then this one is a mucinous cystadenoma. They usually attain huge dimensions. So if it is a very big cyst, bilateral or even unilateral, only the thin wall is seen. It could be multiloculated. So large multiloculated cyst is usually a mucinous cystadenoma. Extra points, they can grow very large, and there is a risk of pseudomyxoma peritoni if it is ruptured. At times, these cysts are not identified, and then there are multiple sites where drainage has been done, and then they again regain their normal size. They grow even bigger when fluid has been removed from them perabdominally. So this is an important thing which could be asked and which you need to mention. The basic differences between a serous cyst and mucinous cyst. Mucinous cyst is invariably multiloculated, while a serous cyst is unilocular. And the contents, of course, in a specimen we cannot see, but on questions which the examiner asks, you can explain that a serous cyst is usually bilateral, mucinous cyst is unilateral, huge size can be attained, it has multiple septations, and it has mucinous content. Then next important thing is a dermoid cyst. This is invariably a common viva specimen. And a surface, you may have a single big cyst with a cut surface, which may show many structures. Most conspicuous of it are the hairs which are seen. Sometimes the other structures are not seen. So hair, sebaceous material usually gets dissolved in that fixative thing. But tooth, bone, and a dense rocky tansys tubercle can be seen in most of these cases. So an ovarian dermoid cyst can be identified because it has many of these structures present. There's a benign germ cell tumor of the ovary. It contains elements from the 3 germ layers, epiderm, mesoderm, and endoderm. It has a thick capsule. On cutting sebaceous material, hair tufts, which are characteristic. At times, you may see teeth, bone, cartilage, and a solid projection, which is the dermoid plug, is the Rokitansky's tubercle. So this is how you can identify a dermoid cyst. And then clinical questions that, because it is heavy, it usually tends to lie in the anterior to the uterus. In the anterior fornix, you may be able to identify it. At times, it could be bilateral. It is lined by stratified squamous epithelium, contains hair follicles, sebaceous cysts. It may even contain sometimes thyroid tissue cartilage. It is common in young women, 20 to 40 years. They are often asymptomatic, and it could be an accidental diagnosis when an ultrasound has been done. Or some girls, if the tumor is quite big, may present with an abdominal mass. And then I've seen cases in which they've had some activity like running or swinging, and then suddenly torsion has developed. Sudden onset of pain, maybe because of torsion. Various complications, rupture may cause chemical peritonitis. Infection is rare. You're always asked about malignant transformation. Yes, it can undergo malignant transformation, and the incidence is 1 to 2%. Then various investigations would help in diagnosis, like an ultrasound. Tip of iceberg sign is seen, an ecogenic mass with shadowing is seen. Sometimes teeth are seen, or some shadows typical of cartilage can be seen in it. CT, MRI can be also diagnostic. They can show us the fat and calcific deposition in it. Then when you're good at everything, usually the examiner asks you about the management, the surgical removal. If the patient is young, only a cystectomy may be done. But if she's completed her family size, and if it is substantially very large, then it has to be removed, an oophorectomy. The most important point which should be mentioned is that at the time of surgery, whether it is an open surgery or even a laparoscopic surgery, this fluid should not spill out, because chances of chemical peritonitis are as high as 5 to 10% in all such cases. So in a bag, you need to morcellate it, or you need to open out the contents in a bag and then remove it. So these are the various types of dermoids. A classic dermoid, then dermoid with Rockestansis tubercle. Here teeth and bone are seen. Sometimes they could be bilateral. It becomes tricky when the patient is quite young, and then you need to do you need only to remove. You cannot do an oophorectomy. You only need to remove this dermoid cystectomy. It could be a complicated dermoid in which, if there is a blackish hue on it, it could be because of torsion, it could be infected, ruptured, or chances of malignant transformation are rare, but at times could be seen. So next specimen could be of an ovarian carcinoma. Well, solid and cystic areas would be seen. There would be an irregular surface and necrotic areas. This will help in identifying whether it is malignancy. And if the whole of the ovary is removed at times, you could have, in addition to that, specimen of uterus and cervix and bilateral tubes and ovaries also of the other side. That would help in identifying that it is a case of ovarian carcinoma. Ascites is often present. These are the identifying points. Then it could be a fibroma, which is a solid, firm, white structure, just like a fibroid. It looks like that. Then association with Meek syndrome, fibroma plus ascites and pleural effusion. Then granulosa cell tumor, which again has solid and cystic areas, but is compared to carcinoma or compared to fibroma, it is quite yellowish in color. And here the viva point is precocious puberty and postmenopausal bleeding. Then Krukenberg tumor, as we know, are as a result of secondary deposits in cases of malignancy. So they are essentially bilateral, solid, bosselated appearance. And histopathology, signet ring cells can be seen if it is origin from the stomach. So as you can see, these peculiar things can be seen, and this is how the structure can be identified: an ovarian fibroma, then a borderline mucinous tumor, mucinous cystadenoma, serous cystadenoma, ovarian granulosa cell tumor, yellowish structure, solid and cystic, bilateral bosselated appearance in cases of Krukenberg tumors, an ovarian dermoid in which you see the hair, an ovarian carcinoma in which necrotic areas are typical. Then a list of common questions which could be asked. First, you may be asked to classify ovarian tumors, essentially epithelial, germ cell, sex cord tumors, and metastatic. These are the 4 varieties. Then most common benign tumor is an dermoid cyst. Most common malignant tumor is a serous carcinoma. Bilateral tumors could be a serous cystadenoma or a Krukenberg tumor. Then tumor markers for epithelial tumors, CA125, alpha-fetoprotein for yolk sac tumor, HCG for a choriocarcinoma, and for germ cell tumors and dysgerminoma, we have LDH. Various complications which you all know: torsion, rupture, and malignancy. Now, always mention whether the tumors are bilateral. Always describe the contents. It seems could be having serous content, so it could be a serous cystadenoma. If it is multiloculated, thin-walled, and it could be a mucinous cystadenoma. Hair, teeth are seen. Always describe it as a dermoid. And if it is irregular, the typical look of malignancy, so label it as an ovarian carcinoma. So subsequently, depending on the structure which you have identified, further questions would be asked. If it is a malignancy, then of course the staging and then the subsequent management. So it depends on all what you identify and what you explain. Depending on that, further questions are usually asked. These are the 2 common tumors of the ovary, and this is how you can easily identify them. A serous cystadenoma, as we had already seen. Unilocular, multilocular with sticky mucin is a mucinous cystadenoma. Now, if there are evidence of cystic and solid areas, it could be a serous cyst adenocarcinoma. Mature cystic teratoma is the other name for a dermoid cyst. A dysgerminoma looks somewhat like this. solid white and lobulated. This is how a fibroma looks. And then hemorrhagic and yellowish structure, granulosa cell tube. So that was all about the ovarian tumors. So now, because students are not there in this, I cannot ask them questions, but a brief overview how to identify and how to explain them. And then subsequently, as students are already have given their theory exams, they would be easily able to explain and give answers to the question which the examiner has asked. Now, a few more interesting things which can be asked, and specimens which are kept, specimens of the tube. Like this one. This one you can easily see that cystic area is seen in the tube, and it seems to be an ectopic pregnancy. In this case, teoma seems to be a teomas. So these are the two commonest fallopian tube specimens, that of an ectopic pregnancy. Sometimes a sac-like structure is hanging out from the tube, and you can easily identify it. And then there is an hemorrhagic area in it. So if the fimbrial end, dilated ampulla end, and ampullary end is seen, it could be of that of with blood clots, it could be that of an ectopic pregnancy. And these are the various differentiating features. Here is a teomas in which you would see the tube along with the ovary, and that too stuck together, adherent, yellowish. And this is how it can be identified. Now, a few specimens of the uterus, cervix, tubes, and ovaries. If you get a specimen like this, you can easily identify that it is a total hysterectomy specimen. At times, you may be able to tell the route of surgery. So if you get something like this, obviously it is an abdominal surgery. In vaginal surgeries, you would see that this is cut flush. There is very less parametrial tissue. And in laparoscopic surgeries, multiple cuts or morcellated, it is morcellated. So you may get multiple cuts, or it has been bisected in half. It could be a vaginal surgery, or it could be a laparoscopy. This is how you describe the route of surgery, which is at times asked. So a normal uterus with cervix, tubes, and ovaries, in which this is the total hysterectomy specimen. Sometimes they ask the age of the woman also. Like in this, if you have a uterus with a large fibroid, she could be of a reproductive age group who has completed her family, or she could be an elderly age group in which she had abnormal uterine bleeding. And because it was a submucous fibroid, it had to be removed. Uterus with endometrial polyp, and here cervical cancer. I have another specimen of cervical cancer, which would come later. Then various uterine anomalies also can be asked, like this is a bicornate with single cervix, bicornate uterus with unicornis, single cervix. You need to flip over the specimen, see if there are two cervix or there is a single cervix, and whether the tubes and ovaries have been removed or not. Now about this specimen, what do you think? So this is a vaginal hysterectomy specimen. So mostly a case of uterocervical prolapse. And this can be easily identified that vaginal hysterectomy has been done because of this supravaginal elongation. This is the attachment of the vagina, this is the cervix, and supravaginal elongation of cervix identifies that it is a case of prolapse, and most common route is a vaginal route through which surgery has been done. Then we do have specimens of hydatiform mole in which the uterus could be larger than normal size. So if only a suction evacuation is done, then you would see only these grape-like vesicles in that specimen jar. But at times, especially in the older times, when we used to do a hysterectomy with the specimen in situ for cases of invasive mole or for multiparous women, we still do have a specimen like this in our department. And the commonest question in this is, why do you think a hysterectomy has been done? So here a hysterectomy could have been done either because she had completed her family, or which is not the answer nowadays, or it could be an invasive mole which was perforating outside and a uterus had to be removed. So hydatiform mole is a proliferative disorder of placental villi. and the products of conception are replaced by swollen vesicles. This is easily identified. Vesicles, thin wall, translucent, and they could vary in size. This is a complete mole, but there could be an incomplete mole in which fetus also can be seen. Fetal parts can be seen. Here, typically, fetal parts are absent. So as a bunch of grapes and on ultrasound, the typical snowstorm appearance. If you get a specimen in which the uterus, tubes, ovaries are there, and lot of parametrial tissues there, try to look at the cervix for any evidence of malignancy. Usually these specimens are of cervical cancer. The growth could be exophytic or endophytic. If it is endocervical malignancy, then a big barrel-shaped cervix would be seen. Necrotic tissue would be easily identified, and this is how you would be describing that specimen. This is something rare, not that rare, but nowadays we don't get any such. But this specimen, if you see in details, arrow marks the presence of a coiled plastic thing, which is in the olden days we used to apply Lippy's loop. So Lippy's loop in situ, a specimen of the uterus with tubes and ovaries. So total hysterectomy specimen. Anterior surface is cut open, and you can see easily that the muscle is thick. There is adenomyosis and there is endometrial hyperplasia, and the structure is seen inside, which is an IUCD, the Lippy's loop. So neglected Lippy's loop left hand side, and ultimately she had a hysterectomy. So these were the specimens I thought were important in gynec besides fibroids. Thank you. If you have any questions, I would be happy to answer.
Thank you so much, Anupama ma'am. I think it was very an excellent class for the students, and I think the way it need to be asked in the question, and you have given the outline of how the questions to be asked, that will be really helpful to the students. So maybe from next in the class, we would like to have a few students as well as, so that we can have the interactive, and then you can find out how the students will do. So that will be better for in those sessions. So thank you so much, ma'am. I would like to have you involved in our future academic activities also as well. And I'm sure this will be very much helpful to the students. And this class will be in recording in the ICOG website. So student can go back to later on to the website and see how it is helpful. Thank you so much, ma'am, for your an excellent class.
Thank you.
So would like to have move over the last session, that is on the, in fact, rather an exciting session for the students. For these students, many times join, and we have increasingly been popular this session, and that is on quiz. So we have our quiz chairperson of the quiz committee, Dr. Archana Kumari. Then Dr. Rijesh Robi. So Dr. Rijesh is the national coordinator, and Dr. Priya Kanapan, she is South Zone coordinator. So I'd like to invite the quiz committee team to kindly conduct the quiz.
Thank you, sir. Thank you for the opportunity. Can you hear me? Yeah, Dr. Rajesh is traveling, so I will be sharing my screen. So he's there. So I just hope somebody will allow me to share. Yes. Yeah, thank you. So for people who already know the quiz, you know that. For people who are new to this, so this is in the Kahoot platform. So you can either enter into www.kahoot.it, and then you can put this quiz pin. I'll just give a start. Or you can screen the QR code. And that will enter into that. So The moment we start, we'll not be able to allow participants inside. So I will wait for all the participants to come. Kindly give your full name so that it is easy to call you out when you're in the top 5. And it is proud moment for every professors to see their students coming on the top 5. So kindly give your full names. Yes, thank you. So I will give you some more time. So you can take your Google browser, go to this, scan this, and you'll be entering directly the website. Or if you already have a Kahoot app, enter the game pin 729099. Kindly keep yourself muted and kindly try not to scribble on the screen.
Dr. Priya, you can click on the QR code so that it will be enlarged. So that if anybody wants to.
Yep, done that. Thank you.
Once again, thanking ICOG for involving quiz committee in the monthly programs. And each time the 4 zones take turns to conduct this program. This time, this is South's turn and Dr. Priya Kandapane, South Zone coordinator. Since Arsana madam is not here, I'll be doing the first few questions and then Dr. Priya will be taking over.
So I think the host will have an access to see how many people are there in the PG students so that we will know how much time more to wait.
You can give maybe another 2 minutes.
Yes, sir, we'll do that. And maybe somebody can mute all the participants so that it doesn't interrupt the quiz flow. Thank you, sir. Thank you.
So almost hit 40, which is a okay number for an online quiz. Hopefully we'll cross 50.
No, South Zone always many people come. Maybe another 30 seconds, I think we should start. Before the other participants are already inside leave, I think we should start by 30 seconds.
So I think they can join even if you start that also, right?
Usually in Kahoot, it's a little difficult to join after we start the quiz, sir. So that is the only problem with this platform. I mean, they can, like follow as a participant and they can enjoy the questions to see whether they know or not. I mean, the numbers are decreasing, so I'm really worried that we're waiting to lose more people.
You can start.
Yes, I'm starting. Yes, sir, sure.
The host team, I don't know who is, there is some noise in the background.
Yeah, kindly, ask them to do that. Yes, I'm starting with the quiz. So before the people who have already joined, let them not leave because the numbers are reducing. So I'm starting. So kindly don't leave it. Please stay back inside.
So you can start.
So Foxy ICOG PG quiz. The first section is on definition, etiology, and screening. So which is the best parameter to differentiate SGF from FGR? We all know that it's the most difficult thing for a obstetrician part. So whether it is fetal weight, whether it is Doppler, AFI, or whether it is maternal weight gain, it's differentiate SGF from FGR. So majority has got it correct. It is the Doppler which differentiates SGF from FGR. Do is the Doppler. Going to the next question. So what is the prevalence of FGR, which is the correct statement? Whether early onset is less than 5, late onset is more than 90, early onset is around 30, late onset is around less than 30. Which is the correct statement regarding prevalence of FGR? So majority has got it correct. The early onset is around 30%, and majority will be the late onset FGR. So next. So Nirosha has got proper question. Next. So it's not a common etiological factor for FGR, not a etiological factor. Biotic air pollution, single umbilical vessel, BDS. This is not an etiological factor. Related easy question. Oh, many has got it incorrect. GDM is usually for macrosomia, not FGR. So that is the correct answer. Next. So Priya is on the top. Next. It is not a screening test for FGR. PAPE, TLGF, AFP, beta HC. So we have many screening tests for FGR with the inverted pyramid of antenatal care. Early screening of FGR is always recommended. So which cannot be used as a screening test for FGR. Many has got it correct, beta HCG, because placental factors will be supportive of assessing and screening for IUGR. Next. False statement on risk stratification for FGR. It should be done in the first antenatal visit. Biochemical marker is used for universal screening. If high risk undergoes surveillance from 24 to 28 weeks, USG markers is not used for universal screening of FGR, which is the false statement. Biochemical markers is not used for universal screening of FGR. So I will stop here and I will let Dr. Priya Kanappan to take from me.
Okay, thank you. Thank you, Dr. Rajesh. So Dr. Rajesh has been traveling. So like, thank you for joining in between your flights. So that's kind of you. Why we kept it as biochemical markers? Yes, it has a role, but it is not recommended by the FOXI for universal screening. So that is why is like, it's a wrong answer. And USG marker is definitely not used as universal screening. It is not a screening. Once you diagnose, then you follow up with the ultrasound. So the scoreboard, there is a change with Dr. Priya Topper, followed by Dr. Janvi and Geetu. Role of aspirin in prevention of FGR. Identify the false statement. Recommended in women with an increased risk of preeclampsia and FGR. The dose of 150 milligrams should be started between 12 and 16 weeks. Recommended in all cases of FGR. Considered in selected cases with placental mediated FGR. That's the false statement. Wonderful. Most of you have got it correct. So either if there is FGR may be related to preeclampsia or a placental cause, then the aspirin has a role and it's not recommended for all cases. Excellent, guys. So Dr. Priya followed by Dr. Geetu and Janvi. Good, guys. The early onset FGR is defined as less than 28 weeks, less than 30 weeks, 32 weeks, 34 weeks. This we should be very clear. You cannot go wrong in this question. Wonderful. So 32 is the cutoff for FGR and 34 is the cutoff for preeclampsia. So good. Scoreboard remains the same. Most common cause of early onset FGR. Is it the torch infection, the placental insufficiency, chromosomal defect, or the genetic syndromes? Which is the most common cause? All are the causes, we know that. Of which, what is the most common cause? Okay, yes, we get confused. We know all the things will cause, but still the most common cause for both early and late is placental insufficiency. So there is the scoreboard change. Dr. Nivedita has climbed to top 5. Good. Give me a true or false statement. According to Delphi, isolated estimated fetal weight of less than 10 centile is FGR. Wonderful. Because only a low weight is SGA. So we know that. Scoreboard remains the same. Diagnostic criteria for early FGR. is less than third centile, the estimated fetal weight, umbilical artery PI of more than 95th centile, abdominal circumference less than the 10th percentile with the uterine artery PI of more than 95th centile, all the above. Excellent. All the above are true statements for early FGR. So there is a change. Dr. Priya, Geeta, and Nivedita are top. Good, guys. Which is not a criteria to diagnose early FGR as per the Delphi or the ICOG. Estimated fetal weight less than the third centile, AC less than the 10th centile with the uterine artery PI of more than 95. Estimated fetal weight of less than the 10th centile with the umbilical PI of more than 90 percentile. AC falls more than 2 quartiles of growth with umbilical artery PI. Excellent, because this is a criteria, but it is for late onset FGR and not for early onset FGR. So don't take it that this is a wrong statement. It is a right statement for late onset FGR, not for the early. So scoreboard remains the same. Brain sparing effect is indicated by CPR less than the 5th centile, CPR more than the 95th percentile, MCI PI more than the 95th percentile, MCI PSV more than the 95th percentile. So we know all these other measurements which we take in the Dopplers, which tells you it's brain sparing. Okay, a few of you have got confused. Isolated MCI PI increase is not that much predictive compared to a CPR, which means the flow in the brain is better than the flow in the abdomen. That is brain sparing. So scoreboard, we have few people. Dr. Neha and Hiba has come to the scoreboard as well. Dr. Priya stays on the top. Placental histopathology finding is more profound in early onset, late onset. Both will have the same finding. There is no change in the FGR at all. Excellent, excellent, guys. It is more pronounced in early onset. So, wrong statement on the symphysiofundal height on FGR. Increases by 1 centimeter a week between 14 and 32. Plotted in a chart from 24 weeks. A lag of more than 3 centimeters is diagnosis of FGR. It's a very accurate measure in high BMI patient. Excellent. It is not much useful in high BMI patients. So in scoreboard, Dr. Priya stays and Dr. Nirosha is climbing up. So the next session will be more on Doppler and a little bit of management. Identify the normal uterine artery flow. So I've given images of these 4. Which one gives you the normal uterine artery flow? So see the images and tell me which looks normal to me. All of them are uterine arteries. I'm not confusing with other arteries. Yes, you can see the image. The first image shows a diastolic notch. Even the 4th one has a diastolic notch. Second one, you can see a notch along with a very reduced flow in diastolic. And the third one is a normal flow. So scoreboard, there is quite a change. Dr. Nivedita and Nirosha climbing up. Good, guys. First Doppler abnormality to appear in early FGR. MCI PI decreased, umbilical artery PI increased, ductus venosus A-wave reversed, CPR is reduced. First one. Excellent, excellent, guys. You have understood your topic well. So there is a change. Dr. Nirosha is climbing up. Good, guys. Most sensitive Doppler in the late onset FGR. Is it MCA PSV, umbilical artery Doppler, a ductus venosus Doppler, or CP ratio? Excellent. Umbilical artery sometimes can still be normal, but the ratio will be altered in your late FGRs. So scoreboard, Dr. Geetu is back in the scoreboard. Dr. Nirosha stays on top. The most sensitive Doppler for fetal acidosis in early FGR is MCA, umbilical artery, CP ratio, ductus venosus. For fetal acidosis. Excellent. All these will have an effect. Yes, your acidosis is a near premorbid condition which appears just before you're stillborn. So that means what is the late change to happen, and that we know is your DV. So Dr. Nirosha stays there, followed by Dr. Hiba Rizwan and Priya. Okay, very good, guys. Congratulations. The absent end-diastolic flow in the umbilical artery indicates mild placental insufficiency, severe placental resistance, reduced fetal perfusion, brain sparing effect. Excellent. I really didn't expect this. This is very good because your umbilical artery is the one which carries blood back to the placenta. So it just says the placenta is resistant so that it is not able to push the blood. Usually your placenta resistance is so low that the blood will be a forward both in systole and diastole. And in FGR, the resistance is more so that it is pushed back in diastole. Okay. And umbilical artery does not supply the fetus. It takes the blood back to the mother. So it is a sensitive indicator for placental resistance rather than baby. So Dr. Hiba has climbed to the top position, followed by Dr. Nirosha and Nivedita. So the Doppler abnormality, which is important in late onset FGR, is, I think we have already discussed, so it should be a EC point now. The decision making depends on this Doppler in late onset FGR. Wonderful, guys. Excellent, excellent. So scoreboard pretty much the same. Dr. Priya climbing up. According to the RCOG, Maxwell for neuroprotection is recommended up to 30, 32, 34. It's not recommended at all. We are not asking about consider. We are asking about recommended. Okay. It's according to your FOXY and your ACOG, it's 32. Your RCOG recommends up to 30, and you can consider between 30 and 34. So be clear with your guidelines. Scoreboard is pretty much the same. Steroids in FGR is recommended up to which gestational age? 30, 34, 36, 38. Simple question. Excellent. Up to 34, it is recommended. Okay, there is a small change with Nivedita climbing up. Hiba stays on top. Identify absent end diastolic flow in umbilical artery among these images. Excellent, excellent. Or most of you got it correct. Excellent, guys. So Dr. Hiba stays on top. Identify reversed A wave in DV Doppler. From these 4 images, which shows reversed A wave. Excellent, guys. Excellent. So you should not get confused with this. This is just an inverted image of DV. This is perfectly normal DV. And in this image, you can see the downward one, which is a reversed A wave. So scoreboard remains the same with Dr. Hiba on top. The more severe pattern of FGR in umbilical artery among these four. All four are umbilical artery Dopplers. Which do you think is more severe form? Excellent, guys. So this is the normal flow. This is a reduced flow, absent flow, and reversed flow. Excellent, guys. Excellent. So Dr. Hiba stays on top. 28 year, I mean, these are case scenarios. 28 weaker, primary, with the estimated weight of 2 centile, umbilical artery, absent endosteric flow, TB normal, CTG reassuring. What will you do? So 28 weaker with absent endosteric flow. No. No, why do you deliver at absent endosteric flow for a 28 weaker? We wait till reversal or we even wait up to TB. When the TB is normal, we don't plan delivery. Okay, only when your TB is becoming abnormal, you give steroid and deliver. So Dr. Nirosha has climbed up to the top. A second gravida, 30 weaker, estimated weight on 3rd centile, reversed endostolic flow, your DB is abnormal, CTG is non-reassuring. You wait for 48 hours, you emergently deliver, repeat the Doppler in 24 hours, complete the course of steroids and deliver. Okay, few of you have thought you'll give a steroid, but this case, your DB is abnormal, CTG non-reassuring. So if you don't deliver within a few hours, this baby is going to die. We don't have the time to complete the steroid course. Okay, you will give a steroid and deliver, but you will not complete the course. So in scoreboard, there is a change. Dr. Nirosha, Hiba, Neha, Geetu, and Nivedita. Very nice. And few of you have got it very good. Dr. Sonali has got many things on the row. Indication for cesarean section in FGR is all FGR should be delivered by section. Preferred mode in term FGR. Preferred mode in all FGR when the uterine artery PA is more than 95%. Preferred mode in preterm FGR. Simple question. Excellent, guys. We deliver preterm only when there's a significant Doppler change. Otherwise, just because they are FGR, you're not going to deliver. So a significant Doppler change when your decision for delivery is always by section. Lovely. So Dr. Nirosha stays there on top. 36 weaker with the estimated fetal weight of 5th centile, normal Doppler, normal AFI. What do? You induce immediately or you deliver at 37 completed weeks. Continue till 40 weeks. Immediately you'll do cesarean section. Excellent. We don't wait up to 40 weeks for a patient who has a lower centile because we know it is a placental problem. We will not wait till that period. So whenever she's term 37 completed or 38 week, you will deliver. So Dr. Hiba is back on top, followed by Nirosha and Geetu. This was made a comeback with she's on fire. Come on, guys, few more. Neonatal complication does not include hypoglycemia, hypothermia, neonatal jaundice, anemia. One of this is not a complication of FGR. Excellent. Okay, because they have polycythemia because of chronic hypoxia stimulating more RBC production. Okay, so Dr. Rehmat is there on the top list. Good. Dr. Hiba, Nirosha. Wonderful, guys. Long-term complication does not include diabetes, liver cirrhosis, atherosclerosis, risk of CKD. One is not a long-term complication. Yes, we have a doubt. No, we know atherosclerosis. Yes, hypertension, diabetes, a lipid profile elevated. That is risk for atherosclerosis. We know that. And it is proven that it can cause CKD. Liver cirrhosis is not directly related to your FGRs. So Dr. Nirosha climbing to the top. So few more questions. Truffle study in FGR is about PV changes, neurodevelopmental outcome, PV changes and RDS, CTG changes with neurological outcome, PV changes and stillborn. Excellent. This is one point we all should know about FGR. Why are we waiting till late DV changes before we deliver? Because Truffle study has found that when they compared early DV changes and the late DV changes, the neurological outcome were not that very bad if you wait even till later, because the prematurity is causing your neurodevelopmental problem. So don't deliver early. Wait till you have a little more of time and wait till you have a wave reversal and then you deliver, rather than when you have a mild changes in DV, you need not deliver. So that was a conclusion which Truffle study gave us. And it did increase your risk of stillborn. So we have a change in the scoreboard. Dr. Nirosha stays on top and few of you have climbed back to the scoreboard. Excellent, guys. Excellent. So last question. Everest clinical trial is about use of PLGF instead of Doppler in managing FGR, tadalafil to improve the birth weight and prolong pregnancy, risk of prematurity with FGR, maternal vascular endothelial growth factor gene therapy in severe early FGR. So it's a Everest trial. Okay, yes, this is a very correct answer. They have tried this gene therapy and that has been found to be useful. All these are also trials, but they are not Everest trials. Okay, so we will have our scoreboard. So the podium. Third place, Dr. Rahmat. Congratulations. Second place, Dr. Nirosha. And first place, Dr. Hiba. So congratulations, guys. Congratulations. We have our four, Dr. Geetu, and I'm not sure, I cannot see that name. So congratulations, all of you. And thank you, ICOG, for such a wonderful opportunity. And thank you, Dr. Rajesh. And I thank Archana Madam for giving us this opportunity.
Thank you, Priya Madam. Thanks a lot. The questions were framed so that it is also a limited break class from history and to the neonatal complications. And thank you, ICOG, for this opportunity. And it was nice competition also. All the students were answering almost all the questions, and there was a good fight at the top also. So it was nice.
It was changing.
Nice
The scoreboard was always changing. So it was very nice to see.
Thank you so much, Dr. Priya and Dr. Rajesh. And congratulations to the students for participating and especially for the winners, those who have won the quiz. So I'd like to sincerely thank you, all of you, and especially the FOXI president, the ICOG chairperson, Dr. Sheila Mane, then chairperson-elect Dr. Ashok Kumar sir, and Dr. Ashish. For the first session, Dr. T.V. Chitra. And then with the students of the Silsar Medical College, Dr. Riba, Dr. Ahmad for participating in the case, and their guides, Dr. Pranay Nath and Dr. Fuzail, and all the faculty for the case discussion, Dr. Ashish Kumar Mukhopadhyay, Dr. Padmaja Vai Madam, Dr. Upma Saxena, Dr. Jasmina Begum, and Dr. B.M. Rupakalam. And for the specimen session, I'd like to sincerely thank Dr. Anupam Madhave for taking the second class. And last but not the least, for the quiz session, the team of Dr. Archana Kumari and Dr. Rajesh and Dr. Priya. So thank you so much for all of you, and thank you all the students for participating. So in the next month, in the month of May, we'll have another session on second Sunday of the month. So I'd like to sincerely express my thank you for all of your participation and time on the second Sunday of the month. Thank you. Ramnath, can you stop the recording?
Yes, sir. Thank you, sir. Thank you for the opportunity. Thank you.
Yeah.
Thank you so much, sir.
Thank you, ma'am.
Okay. Bye-bye, students.